the following. 4 participants are in the conference.
AV room?
Hello? Hello?
Hi, how are you?
Yes, I'm okay. Thank you. This is Susie.
Hi, Susie. This is Rachel Martin. I'm from Blue Cross.
Are we on a teleconference?
We are on a teleconference.
Okay.
Is it recording? Oh, okay, there we go. Thanks. Is the call to public? Any of the 5 people out there want to speak? No? Okay. Number 2, opening remarks, introductions, which I guess I just did, and agenda review. Mr. Collins.
Madam Chair, thank you. For the record, my name is Aaron Collins with Aaron Collins Associates / Gallagher with the consultants to the trust. Just a couple of opening remarks. So in recognition of the new world that we are currently in, obviously the vendors, with the exception of Meritain and our firm, will be online. We have notified them that we are going to stick to the schedule of time. Basically, they all got a text this morning that reminded them that this is a gong show, that they will stick to their minutes or they will be gonged and get the hook and be pulled off. So they will be participating by phone. Please bear with us on the technology. Amanda, to my left, will be madly texting. That will not be on her social media account. That will be with vendors, keeping them teed up and on time. And then we did find out this morning that one of the vendors with EAP Preferred, Carmen de los Reyes, is ill. She lost her voice. So she is madly hustling about trying to find somebody for her 10 o'clock slot. In the worst case, we will just do a brief conversation and we'll give that slot and we will continue moving. So the goal is to get us out of here exactly on time while meeting the trust's fiduciary duty to demonstrate positive control over the operations of the trust. That's all I have, Madam Chair.
Okay, can you hear me? Okay, thank you guys. Sorry. Good morning, trustees. I do appreciate the opportunity to be here in person to present to you. It's been a while since I've actually been able to see your faces and things, and last year, being the first presenter, it was kind of nerve-wracking, everybody calling in and interrupting my presentation, so I appreciate it. Today, again, sorry, Rick Seithamel, Account Director at Meritain Health, and I'll be presenting your medical claims. I just wanted to remind you that the claims that I'll be reviewing are the claims that were paid for your calendar year 2020 as compared to 2019. If you want to, go ahead and skip into, I think it's page 10 of your packet. I'll get into the executive summary. I understand that I'm limited to 15 minutes, so I'll try to be brief and allow maybe some time for questions as allowed. I did provide more information, more reporting this year as in compared to years past. That way, if I don't get through a lot of my presentation here, at least you have a lot of detail to kind of peruse it yourself. I'll be here at lunchtime to answer any questions as well in case anything comes up. Looking at the executive summary on page 10 of your packet, areas that influence the cost year over year are a few areas. Demographic, being your membership, whether it goes up or down. Are you think that if you hire more people, you're probably gonna have more claims, but of course it depends on whether you're healthy members or sick members. Same for the opposite. If you had a reduction in force, you would probably expect your claims to possibly go down. Outliers, a lot of times, typically it's been high cost claimants, so every year you have a certain number of people that just have claims over $50,000. 2020 was unique in the fact that our outlier was actually the COVID pandemic, so that had some impact on your claims costs year over year as well. Other areas is your member cost share, which could be in the form of the premiums, whether how much you're having them charge in premiums or how much that they pay for their patient responsibility, whether it be co-pays, deductibles, and co-insurance. Discounts, the number of discounts you have with your networks, whether those discounts are going up or down, depending on the contracts that the providers continue to negotiate year over year. And then finally, your medical inflation. So a claim that cost $100 last year might cost $105 this year. You compound that, looking at a $100,000 claim, it could be $105,000. So all those things in consideration really can drive what cause your claims to go up year over year. So what I'd like to do is just go into the numbers with this executive summary to kind of give a brief overview of those areas. Your membership, you saw about a 5.6% increase to your membership. 80% of those members are on your EPO plan, 20% on the Hideco Health plan, which I still find amazing that there's still so many people on the EPO plan compared to the Hideco Health plan, because I know that if I was a Mojave County employee, I would be on that Hideco Health plan. The risk of it, being $3,000 for an individual and then everything's paid 100% is amazing to me. And then having a health savings account that's tied to it, I just don't understand why there's nobody on the Hideco Health plan. Did you have a question, Hildy?
I thought we did away with the health savings account.
Well, they can
Match.
still, but they can still contribute to themselves, whereas on the EPO plan, you can probably contribute to an FSA, but that's the use it or lose it model, whereas the HSA can continue to compound year over year. Looking at, to normalize things, we do a per member per month. That's that middle top box that you have there. We do that just in case your demographics go up or down. We're still tracking how much it's costing you per member per month on your plan. And as you can see, you saw about a 3.8% increase to that per member per month, how much you're paying on those members. What the good news is that you're still about 16.5% lower than Meritain Health book of business. So all things considered, even though it's increasing, you're still doing really well compared to our book of business. As I mentioned before, the employee cost share, this doesn't take in consideration the premiums, but the out-of-pockets that they experience when they're having their claims paid is an average about 16.6%. This is just slightly over our book of business at 14.9%. But again, it's really interesting when you look at the plans because of the way the Hideco Health Plan is set up. Usually others, that we have on our book of business, it's you meet a deductible and then you have co-insurance and then an out-of-pocket. And so you usually see with those plans that the average member cost share is about 20 to 25%. In fact, your HDHP is actually, for your employee cost share, is actually lower than the EPO because they have that $6,300 for an individual that they have to meet before the plan pays 100%. Looking at your high cost claimants, in the past, I used to just reflect on the top 10. Here we have where we captured all your claimants that are over $50,000. So these are your members that we consider high cost claimants, anything under 50, still kind of high, but 50 and higher, those are the ones that they have some sort of a chronic illness, something is really impacting their claims. The interesting thing is that there's 40 of them. So could you imagine 40 people that if they weren't on your plan, they cost the plan about $4.71 million, which was almost 50% of your claims cost. So if 40 people weren't on your plan, just imagine what kind of a year you'd have. Of course, this is kind of like the strategy behind wellness, right? If we can catch things at an early stage, hopefully we can limit that 40 to maybe 20, 10. So that's really why you want to have a wellness program to try to catch those things at an early stage. Looking at your medical trends, that bottom box there, as I stated before, your demographics went up about 5.6%. We saw that your medical claims, so those number of claims that were submitted compared to 2020 to 2019, we're up about 14.6%. Now, we did have the pandemic. Looking at claims that were associated just with like your antibody test and COVID testing, those are things you wouldn't have had in 2019. So looking at those, you had about 1,100, almost 1,200 of those types of claims, which is about 3% of that increase. Then you had claims where somebody had a surgery done or maybe went to the hospital and they were tested positive for COVID, or maybe they were showing some sort of COVID symptom-like diagnosis. And with those, they had those codes tied with their claims. And although I can't say for certain, would they have been at the hospital or done those services if COVID symptoms weren't existent? Can't tell you that. But we can tell you is that the providers, they billed it with those codes, and that was another 1,146 claims, which is another 2.8% of the claims. So taking those in consideration, that probably added to the increase that you saw in the number of claims in 2020 compared to 2019. The number of claimants increased about 7.3%. That's almost in line with how much your membership went up. It's just a little bit higher. And again, that would probably tie more to the fact that COVID was a pandemic, and you probably had more people that usually if they felt some sniffles or had a cough, they probably would have either just stayed at home, called in sick that day, but people were a little nervous. So some people started going in and just having tests done and found out that they were negative anyway. So you just saw more claims that way. Another increase to it was the fact that telemedicine, the federal regulations wanted us to try to, alleviate some of the pressure in the hospitals. So they allowed telemedicine, which you guys also offered as well. And so we saw those claims go up, big spike in the months of April and May but those kind of started trending down as we got towards the end of the year. Looking at the plan paid, so overall with all of that considered, your claims ran about 10.7% higher in how much you paid compared to the prior year. The ER visits, again, this is a partial impact of the COVID. We saw an increase in the ER, but again, that's why we were hoping that the telemedicine would alleviate that. The whole purpose behind that was to try to get people to call in, if you had a vendor such as Teladoc, utilize that instead of just going to the emergency room because of your primary care physician being closed during that pandemic time. But we still see it. We saw almost a 13% increase into your ER visit. And then on the downward trend was your preventative services, which again, we're seeing that on our book of business, that because of physicians' offices being closed, and then people just not getting out of their homes and getting their mammograms or their physicals done, anything like that, we did see almost a 13% decrease in your preventative services. So 13% increase the ER visits, decline of 13% on preventative services. So the two things that you want to actually flip those, to be more successful with your claims cost. And then finally on this slide, regarding the network, I understand that Blue Cross Blue Shield will be presenting today, so I won't get too much into that. Blue Cross Blue Shield of Arizona is obviously your network within the state of Arizona. You're fortunate enough that you have the wrap outside of Arizona, which is the Aetna Choice POS2 network, which is Aetna's broadest and deepest discount network that they offer to Meritain clients. And the great thing about that is that you actually, year over year, exponentially continue to see higher utilization of that network. So it's definitely being utilized. You saw a 13% increase in the number of claims on that network. And the network average discount is still running about 70.5%, which is amazing. So the people that continue to keep going to Las Vegas, you're getting deep discounts, and it gives them that access if they want to travel or if they have dependents that are out of state. You have that access. So that's what's great about having that network. Any questions on that before I go to the next slide?
Does anybody have any questions? Is Susie on the phone?
Yes, ma'am.
Oh,
I'm
okay,
here.
great.
Good
Berlin?
morning.
I do have a question. Do we know about the increase in the Teladoc medicine numbers?
Yes, so there was an increase during the pandemic. You saw a sharp spike. Overall, your return on investment was for every dollar you spent on that, you're getting about $5.15 back for that service. But then there was a decline, especially as we started allowing telemedicine services. So not just those that are teledoc, but if they wanted to call up their primary care physician and do it telephonically, those were now allowed by the plan. So we saw less, happening with the teledoc program. But the one thing I would stress about the teledoc program is that it's 24/7 service, 365 days a year, whereas telemedicine with your primary care physician is still limited to their hours. So it was still a great benefit. We did add the behavioral health piece to it on July 1st. I think that because of maybe the pandemic, maybe not a lot of members were aware of it. On the Heidelberg Health Plan, we didn't see any utilization of it at all. But on the EPO plan, there were about 11 members who utilized that piece, which is great. So some people are actually utilizing it for that mental health piece that we really want to try to get out there. But unfortunately, with the cost right now, you're probably spending more on the behavioral health part. But we feel that as soon as you start promoting it more, if we get out there and get in front of people, we didn't have benefit fairs, open enrollment meetings were virtual. So just try to get that information out to your members. I think that it would be a great benefit, because a lot of them, the behavioral health services in this area, I understand, are very limited. So having that extra piece is really good there. You have any other questions about the teledoc? Or I understand I only have a couple minutes left, and I'd rather answer questions. I left keeping me honest here.
Got a question, Madam Chair. So would you say that the results that we have here are very representative across the industry of what's going on in both claims?
Yes, I would definitely, with the presentations I've been doing so far this year, looking at 2020 figures, preventative services down, ER visits up, your high cost claimants, again, 40 people, but of course that's looking at 50,000 and more. If I look at just your top 10, you actually saw a decrease, looking at your top 10 high cost claimants in 2019 versus 2020, you actually saw like a 17% decrease in those memberships. So your claims are actually running a lot better. And again, that's why we have that per member per month to kind of normalize how you compare to our book of business. And again, you're running 16.5% better than our book of business.
Well, thank you.
You're welcome. No more questions? Or
Questions? Any more?
believe me, I had a lot to talk about. There's so many things in here, but again, if you guys go through your packet and you need anything, I can always be contacted, email, phone. I'll be here at lunchtime.
Okay.
So
I want to make sure. Susie Duranzo, do you have any questions?
None at this time.
Okay, thank you.
thank you again for your time.
Hi, good morning, trustees. This is Missy Jensen with ECA Gallagher. I just want to make sure that everybody can hear me okay.
Now, you're going to need to speak up, Misty, because you're pretty soft.
Oh, okay. I will try to talk loudly, so please just let me know if I'm too quiet. I'm happy to try to yell into my phone if needed. Okay, so I'll be walking through a high-level overview of the wellness program that has been implemented. We'll be focusing mostly on the last year, the last fiscal year, and parts of 2020 that fell into the prior. And I will make sure that it's noted in the presentation so you can follow along. And with the interest of time, I do want to let you know that I will be focusing more so on the executive summary portion and a handful of slides that follow. However, I do have an appendix as well that goes into greater detail on some of the other program opportunities that have been implemented and have more information, and I'm happy to pull out any of that if you're interested in looking a little bit further into any of that content. So I'm going to start on slide 2, but that's going to be page 55 in the packet. So the major focus for the presentation today is areas of opportunity, highlight some of those existing programs, high level, and then looking at some program considerations for trustees. As far as areas of opportunity, these are really the high points that a wellness program can address with various strategies and things that we've already done. So musculoskeletal disorders have been number one, number two for many years. Endocrine, nutrition, and metabolic disorders are really focusing on those diabetes-related claims. Circulatory disorders are those heart disease areas and cardiovascular disease opportunities. Neoplasms focusing on cancers, and then mental and behavioral health disorders. I'll be diving in a little bit deeper into diabetes and heart disease along with neoplasms in a little bit greater detail in the subsequent slides. As far as how we're actually addressing some of these areas of opportunity through the wellness program, we've offered a variety of different efforts that address both lifestyle and medical and other things like that to actually provide a well-rounded program. In doing a review, I was able to see that 40% of employees of Mojave County have actually participated in at least one program initiative in the last year. So that includes Livongo for Diabetes, Walker Tracker activity challenges, any number of the screenings or services. And that's a pretty great number to see, knowing that almost 50% of your employee population has actually engaged in one of those opportunities. So really fantastic to see. As far as those specific programs, I just wanted to pull out some high-level details here. So Walker Tracker was implemented last year, and so we've offered a variety of physical activity challenges to help address both risks for diabetes along with heart disease risk factors, which a lot of blending happens there with those. So that's why exercise is one of those components that we like to focus on with the wellness program. In doing a survey of employees actually it was back in October, we surveyed employees just to get satisfaction, kind of get a pulse on how happy are people with the wellness program, how are you engaging in these activities, what activities do you enjoy, what areas of opportunity are you really wanting to get more information or more support on for your overall health and well-being. And we saw that 88% of those individuals that were engaging in Walker Tracker were satisfied. So we're happy to report that people are enjoying that program. Other areas of that survey actually asked about what are some of the topics you're interested in. And that includes things like stress management support, nutrition and cooking, personal health coaching, along with exercise. And so these are definitely high points that we want to focus our efforts on. It's important to match what we're seeing in the medical claims, so looking at those areas of opportunities and then matching that with the wants and desires of the population, so that way we can really maximize engagement. So I think we've done a great job of incorporating some of these, and we have opportunities to further address some of these as well moving forward. And that'll lead me into some of the program considerations for trustees to vote on later today. As far as preventive screenings and services, I just wanted to note we did see a bit of a drop in engagement, and Rick had already alluded to this. A lot of this likely has something to do with office visits and offices being closed, but then also there's that concern with COVID, and so people probably were avoiding care when they probably should be seeking care out of an abundance of caution. So between the concerns of COVID and then some of the screenings having to be canceled, we did see a general decline in engagement. But we do want to point out that each of our vendors that we work with and partner with for these screenings have all enhanced their safety and cleaning protocols to make sure that both staff and their staff and your members are safe. So I just wanted to point that out for you. And then lastly, on Livongo for Diabetes, we do have Livongo who will be presenting information on the program and also doing a proposal. But just to note, we did have 51 enrolled currently, and 98% of those are activated, and people are pretty satisfied with the program. And I'm going to let Julie get into greater detail on that program when she speaks when Livongo is on up after me. So as far as program considerations go, we are proposing to expand the diabetes management program. And on the subsequent slides, I'll kind of walk through the logic behind this. If trustees recall, we did get the request to survey employees, and again, so we did go through and survey employees to get feedback on whether or not they have interest in an expansion to include hypertension management, diabetes prevention, weight management. And we do actually have 2 vendors who will be doing proposals for trustee consideration. And the reason for this is that we were experiencing some administrative hiccups in the last year and a half. But I do see that in my experience, they have resolved that. I think a lot of that was about their growth and ability to handle that growth and that acquisition. So just wanted to let you know that we do have two vendors for consideration that offer a similar program. So I'm going to go into a little bit greater detail then on slide 56. Actually, we can jump to slide 4, which is page 57 in the packet. So again, our focus for today is going to be more so on diabetes, hypertension, and hyperlipidemia. In layman's terms, we're looking at blood pressure and also high cholesterol and then diabetes. So the 2 graphs pictured here include the medical claims at the top and the pharmacy claims at the bottom. So this is looking at the unique number of claimants that had a claim in 2020, and as we can see, the numbers don't match. So we do have some members that will seek medical care for a chronic condition, and others might have a prescription while others don't. And so this just gives you a general idea on how much is being spent on medical and how many members are presenting, and then as far as how many pharmacy claims we're seeing or unique claimants along with that pharmacy spend. So really the key point to note here is that, yes, diabetes appears to be the most expensive medical condition as far as chronic conditions go that we're focusing on here, and it has the lowest number of claimants. And this is really why trustees opted to implement that diabetes management program, because we're seeing this as an area of opportunity to help bend that cost curve and to impact the claims cost trajectory to be able to serve members and provide them with a well-rounded program to address their health conditions. Now, most of these conditions don't happen in isolation. So oftentimes members with diabetes end up having additional comorbidities. So somebody with diabetes is usually at a higher risk for having high cholesterol, having high blood pressure, because all of the lifestyle risk factors associated are common. So exercise, nutrition, and things like that. And so, again, we want to be able to support the total person, and so this is why we're looking at an opportunity to expand the existing program to be able to support a member. And again, you'll hear from both Livongo and Omada to walk through what that looks like. I'm going to jump to the next slide, which is slide 5, page 58. This slide is reiterating that, again, chronic conditions don't happen in isolation. And on the graph on the left, the chart, and I do want to point out I do have a typo. So at the bottom it states 430 members taking 2 or more prescriptions. So that's incorrect. It's 430 members total are taking prescriptions to treat diabetes, high cholesterol, or high blood pressure. So I do apologize for that. But I do want to point out that 40% of those members, of those 430, are taking at least 2 medications. So just proving that there are members who have more than one condition. And the graph on the left is really highlighting that as you add a chronic condition, you're going to see an increased cost to those members, which is why it's important to provide opportunities for members to address their specific condition if they have diabetes only, or if they have additional conditions like high blood pressure or high cholesterol or weight issues. So again, the more conditions a member has, the more costly that member is. And this presents an opportunity for trustees to expand the existing program that addresses diabetes only to also include other opportunities as well. So I wanted to point out the Livongo for Diabetes program. High level, again, we do have the Livongo crew on call next to walk through in greater detail both their program results along with the proposal. But on page 59 in the packet, high-level overview, again, we have 51 members. We have a 98% who have actually used the device, so they're actively engaging in the program. People are liking the program so far with a Net Promoter Score of 67. Again, this is looking at how satisfied are you with the program, and Julie will go into greater detail in this later. We've seen a reduction in the estimated HbA1c from baseline from the program, so that means that members are reducing their A1c, which is essential for people with diabetes. And then in that needs and interest survey that we conducted to gain feedback on whether or not members would be interested in expanding the Livongo program or diabetes program, they would have interest in participating if it was offered. And so we can see that members were interested in some kind of expansion, whether they're already in the program or they would be eligible if it was expanded to include additional opportunities. So on slide 7, page 60, I wanted to walk through the program proposals. So as you've seen, we have a number of opportunities to address the whole person. We have the opportunity to address some of the additional comorbidities that members have. Because as we're seeing, the higher the number of conditions a person has, the higher the cost. So it presents an opportunity for trustees and members to be able to address their specific conditions.
Missy,
So we have two
Missy, it's
programs-
Aaron. You
I'm sorry.
have 2 minutes for the wrap.
I do see that, and this is actually my last slide. Thank you. So on the Livongo Whole Person versus Omada Complete, they are very similar programs in their delivery. So they offer a one-stop shop. They have cellular-enabled technology. Depending on the program, they have professional health coaching, education lessons, and the like. And so both of these programs really present similar opportunities to be able to provide ownership to the member for managing their health by incorporating human touch and then integrating that technology. As far as some of the differences, I do want to point out that with Livongo, they do have a PM pricing. So it's a per member per month pricing depending on the program. And you sign up, you're in it for at least 6 months unless you terminate them thereafter. Omada does offer engagement-based pricing, so there's specific information that they take into account when addressing the pricing and making sure that you're actually actively engaged in the program, so that you end up not paying for anybody who's not engaging. Livongo is offering performance guarantees, so if there are certain criteria that's not met, then there is a credit that gets back to the trust, whereas Omada does not offer that kind of guarantee at this point in time. If Livongo were to be expanded, we wouldn't have any member disruption, whereas if we shifted from Livongo to Omada, we would have member disruption for switching vendors. And then I wanted to provide that overall annual cost, which is pretty comparable. And so the PEPM is $10.95 for Livongo if we were to expand. And then Omada, if we make that switch, it would be $13. So all in all, I see it as an opportunity to expand the program and be able to address those higher risk members who do have those additional comorbidities, and then also providing them with the support needed to address those conditions and essentially help reduce costs to trustees. So I'm happy to answer any specific questions regarding my portion of the presentation or anything else that's in the appendix.
Any questions?
Madam
Willis?
Chairman, this is Susie.
Susie?
Yes, I have a question. The annual estimated cost for the program, for both programs, is that the cost to the trust? Like Livongo, $132,349. Would that be the cost to the trust?
Yes,
The
that is
annual
the cost. That is correct. That would be the annual estimated cost based on projected participation throughout the year, and then I brought it down to a PEPM, so that would be added to that medical or that premium cost.
So basically, the trust would pay the annual cost, and then per person, if you participate, you pay $10.95 per month.
The annual estimated cost is the annual estimated cost. So there's not going to be anything additional unless you have higher engagement. So the annual cost to the trust will be $132.349, and there's no additional cost in that unless we exceed that budget threshold that I set. So there's no additional cost.
All right, thank you.
Okay.
Yeah.
Berlin?
So is it the $10.95 per employee plus the $13, or is the 13 supersede the $10.95?
So for Livongo, if trustees decided to go with Livongo as the vendor to expand, it would be $10.95 per employee per month, and then multiply that by 12, which would be the $132.349. So it would be choosing either Livongo or Omada. It wouldn't be both.
Okay, anyone else? Okay. Next up, we have the Livongo program review and expansion proposal.
Good morning. This is Julie Anderson with Livongo. Can you hear me okay?
Yes, I believe so. Anyone having problems hearing?
Okay, great. So I'm understanding that you guys have slides. So today I will be covering, I'm Julie Anderson. I'm with Livongo. I'm the Client Success Manager, and I work closely with Missy. I also have my colleague, Chris Parks, who will be covering the whole person offering this morning. So what I'd like to do is slide number 81. I'll be giving a high-level summary of the enrollment and activation within the program, the engagement, satisfaction of the members, and clinical outcomes. And then my colleague Chris will be covering the whole person solution proposal, and we'll be addressing questions and answers. So moving on to slide number 83. So in terms of this is an executive summary, which I call it our dashboard, which you can see there are 4 areas here. So in terms of the enrollment for the overall program, we are at 34%, which is at benchmark for the Livongo programs in the diabetes management program. We currently have 51 people enrolled in the program out of an estimated 150 people who could have diabetes. And in terms of the number of people who have activated and using their devices is at 98%, which is fantastic. And in terms of blood glucose checking, people are checking, meeting the book of business at 1.5 checks per day. And this is really dependent upon the member in terms of working with their doctor and how often if they should be checking whether they have type 1 or type 2 diabetes. And moving to program engagement, I'll be drilling down more into this specifically about how members are engaging with the program. And in terms of client NPS, this is the ranking of members if they are most likely to recommend to a friend or a colleague, and that is at 67%, which is very high. If you think about a company like Netflix, they're like at 68. So this is showing that members are highly satisfied with the program. And in terms of the clinical outcome, which is most important, this is showing how people are managing their diabetes. So we are currently at a negative 1.43. This is the change in the estimated HbA1c from the self-reported values for members who started uncontrolled. And these would be members who are greater or equal to 7% for HbA1c and have enrolled at least 6 months. And these are very good numbers. It's showing that people are managing their diabetes well. So moving on to slide number 84, this is just a slide that shows the enrollment and activation of people using the blood glucose. So again, we have 51 people enrolled, and that's 34% of those who are recruitable that we believe have the condition for diabetes. And in terms of the number of people who have activated, meaning using the device, they've taken a blood glucose reading, is at 98%. Moving on to slide number 85. So this is how people are engaging with the Livongo Diabetes Program. And this is showing what people are doing over a 90-day period. And these are the people who are enrolled in the program. So what you can see is 78% of people are connected and using the device within the last 90 days. In terms of people, in terms of how they're interacting, engaging with the program, we have something called self-guided activities. So on a weekly basis, we do send people a summary of how they're managing their diabetes and showing their results, and also providing nuggets of information about things that they can do for behavior change, things as recipes and things like that. We also have people who can log into their mobile device, or they can log into our web platform, so which is ever most convenient for them. We also have lesson sharing about things that people could take classes and learn more about managing a chronic condition. And we also have a health summary report that people can write from their mobile device or from the platform, share their results and information with their physicians through touch of a button within their mobile device. And we also have food logging, where people can log their food and get feedback from our coaches. We also have digital coaching. So within the application itself, we do give people health nudges and really working with them, give them a personalized experience. So based upon the number of checks that they're doing, how their blood glucose readings are doing, we encourage positive behavior change. So we want to celebrate their successes. We want to encourage positive behavior change. And again, these things are customized to the member as we learn more about them. Then we also have expert coaching. This is where people can reach out to a coach to have one-on-one coaching with a coach. We also have alert-based coaching. So on the device itself, we want to keep people within the healthy range between 70 and 180. If people go below 70 or higher than 180, there is an alert that goes off and it's sent to our coaches. And a coach will either text or call the member to talk with them about their reading, checking to see how they're feeling, and try to bring people back into a healthy range. So we really provide education in the moment to help people, again, get into a healthy range. And in terms of members, we also are looking at is how often does a member engage with the Livongo program. And each person is doing that on average 18 times per month, which is fantastic. And these ways in terms of the engagement is really for people to engage in a way that's really personalized for them and based on their lifestyle. Moving to the next slide, number 86. So this is showing the NPS score, and this is just showing member satisfaction with the program. And this is very high. NPS is based on a negative 100 to a positive 100. So anything in the positive number is positive. So this program, members are very happy, and our NPS score is at 67. To the right, you can see some of the member satisfaction questions that we measure on a regular basis. And people are the thing that we look about that's important about the Livongo program, we really want to encourage positive behavior change and helping people manage their condition. So, sorry, did someone have a question? So what we're seeing at the bottom here is people are feeling the more they're longer in the program, they're feeling that their ability to manage their health is increasing over time, and people are feeling better about that. And this is the whole basis of the program, is helping people manage their diabetes and live a really healthy lifestyle. Here are just some comments that people have about the Livongo program. These are some of my favorite things, but it's really talking about how people are using the comments here, how they love it. There's excellent meal plans, great recipes, tracking is easy. They really like that they're getting free supplies and support when they need it. And people are feeling like they're making improvements in their glucose due to the healthy suggestions and facts on the meters. Moving on to the next slide. So, we do want to look at the clinical outcomes. This slide is the clinical outcome for showing for members. So this is the percent of the activated members by the estimated HbA1c group. So we look at people's the first baseline reading and at the 6 month or longer mark. So for members who have enrolled at least 6 months, the share of the members with controlled diabetes, so that's HbA1c with less than 7 for controlled, has increased from 37% at a baseline to 59.3, which is fantastic. And we want to see people who are controlled keep controlled within that area. The share of the members with HbA1c greater than 8, which indicates an above normal blood glucose range, has decreased from 29.6 at a baseline of 14.8, which is great. This is showing, again, that people are managing their diabetes and bringing it into a healthy range. This next slide is just showing the Diabetes Empowerment and Distress Scale. So we do send out surveys to member at the first month, then at 6 months, and then at 1 year, and then every year. So we're really looking at ensuring that people who have the chronic condition, especially in this area with diabetes, is we want to make sure that people are feeling increasingly confident in their ability to successfully manage their diabetes and improve their blood glucose. So at the top is the Diabetes Empowerment Scale. This is measured on a scale of 1 to 5, with 5 being the most empowered. So what we're trying to ensure is that people feel that they're empowered and in control of managing their diabetes. And these are showing very positive numbers. We want to just make sure that, you know, we're seeing people feel empowered as they learn with all the messages and nudges and challenges and lessons and classes that we have, that people are learning how to do that. The bottom area is the Diabetes Distress Scale. So this is really looking at, with people with chronic conditions, often there's a lot of hidden emotional burdens and worries about managing a chronic condition on top of our normal daily busy lives. And so we would just want to make sure, are they feeling less stressed in terms of managing their diabetes? So that scale is on a 1 to 6, with 1 being the least distressed. So as you can see, people were starting in that 3 range and we're moving down into the 1.83, 1.80. So we're seeing a very positive change in terms of people feeling confident and less stressed about managing their condition. So I'm going to be turning this over to my colleague, Chris, who will be covering the whole person proposal.
Good morning, everybody. Can somebody please reply back that they can hear me?
Yeah, we can hear you.
Yep.
Okay, great. Thank you very much. Slide 91, please. This talks about, prevalence for chronic conditions. Today, there's 330 million people that live in the United States, which means almost 50% of Americans have a chronic condition. And most have a comorbidity, which really makes doing everyday normal activities difficult. 86% have weight issues. 56% have hypertension. A third have elevated cholesterol levels. And over 20% have behavioral health conditions. And not to mention, most of our healthcare spend is on chronic conditions. Although you see behavioral health there as kind of like a small oblong circle there, I'm sure you'd agree that depression and anxiety are very prevalent today. With the COVID-19 pandemic, people are working out of their homes, not going to see their physicians, that is if they, can get an appointment to see one, and not be able to socialize like they once did. Behavioral health is becoming more prevalent in society today. Next slide, please. Slide 92. We started, Livongo started as a diabetes management company and grew into a whole person solution as we want to be able to solve for all chronic conditions. I probably didn't have to show this slide to you, because you probably already realize this, but the costs are continuing to escalate. According to data by Milliman, a person with diabetes costs $9,100 to the plan annually. It almost doubles the $18,100 with a comorbidity of hypertension. And then you add behavioral health into the equation, the cost skyrockets to $35,000. So you have to ask yourself, as a trust, what are you doing today to help your members improve their health and well-being? Next slide, please. The whole person solution. We targeted three distinct groups for our whole person solution. People with diabetes, pre-diabetes, and cardiovascular. When you look at these three columns, left to right, our book of business tells us that most people have additional conditions that need attention. Each program focuses on these conditions. So if you have diabetes, you also get to take advantage of our hypertension program, our cholesterol management program, weight management, and behavioral health. If you have prediabetes, which is going to be your most prevalent group, by the way, you'll also get hypertension, cholesterol management, weight management, and behavioral health. And finally, for your population that doesn't have prediabetes or diabetes, but they have high blood pressure, they fall into our cardiovascular solution. So they'll get high cholesterol, weight management, and behavioral health solutions. And you can see the fees right up on top there next to each one of these anchor positions. So, one of the niceties is that when a person signs up for one solution, they can sign up for other programs at the same time. For example, we have found in our book of business that 85% of our members enroll in two programs when they sign up. So again, the data is easily collected, nudges and suggestions are sent to the member, and of course our professional educators are always available to assist members in need. Are there any questions right here on this page?
Any questions? No. Go ahead.
Okay, thank you. Okay, so here's our platform. Here we have our cellular-enabled glucometer, which your members are already currently utilizing and familiar with. With our whole person solution, your members will receive digital nudges and coaching on their phones for behavioral health and cardiovascular conditions. And as you can see, here are our cellular-enabled blood pressure cuff and our scale, shipped right to their home, typically within 3 days after they sign up. So, designed for behavior change. So, health nudges, personalized push notifications are triggered by a member's specific activities, such as logging health metrics onto our connected devices, encouraging a specific follow-up or action. And for example, more than 60% opt in for educational content that's often recommended through these nudges. Our 5-day challenges, those are proactive challenges to help members, fall into healthier behaviors and habits, such as swapping out a processed food for a vegetable or a fruit. And this really brings out the competitive nature in people. And what we have found is that 75% of members in our weight management cohort complete their first challenge. And then expert coaching, Julie kind of talked about this earlier. Our coaches are available 24/7, 365 to talk to members. And, an example of this is if somebody has a low blood sugar reading, they'll get a call from one of our coaches within 2 minutes. So, at this point, I'd like to open it up to questions for Julie or I.
Any questions? Yes.
Curious. 4% enrollment. On the small side. Those are diabetes.
Someone's going to have to repeat the question to me. I can't hear that.
Your microphone on?
I got to turn my mic on. Here we go again. Sorry.
Thank you.
The question is, with only 34% enrollment at 51 out of 150, it just seems so low of a number of people that are taking advantages of these programs. Is it because a lot of those are pre-diabetes and maybe they don't take it as serious enough? Do our numbers represent what you see nationally? It just seems like that's so low. Why is that?
Okay, well, you actually, said one of the answers already, and that is that, I've got prediabetes. It's not a big deal. I'm not going to worry about it. Well, it is a big deal because once you become a type 1 diabetes, there's no turning back. It's not reversible. So a lot of people just, are trying to mentally rationalize away their symptoms rather than, taking action. And today, through January, Livongo, we have 1,400 clients. We have 50% of the Fortune 500 companies as clients of ours, which we're very proud of. And we have over 500,000 members. And 34% of any population, whether you have 100 people or 100,000 people, will actually have type 1 or type 2 diabetes. So your engagement is right at our book of business, Mark. Of course, we'd like to see it higher, and so would you. And that's why we only charge, per participant rather than a PEPM.
Thank you.
So I hope that answered your question.
Berlin?
Nationally, is there a way to target the younger generation? I'm looking at the demographics, and it looks like so many of the people are, obviously, younger than they are the older folks.
Right. Yeah. We actually go down to 13 years of age. I mean, you can market, our pre-diabetes, all three of these programs, the whole person. You can market them to your entire population, but we typically, and we're not going to deny anybody, but most people, once they have a claim, that's how we really, find out who that population is that's driving your health spend up. We really want those people to get engaged and take action. And sometimes, it does take a while. They'll talk to a coworker or a peer. Hey, I had Julie as my coach. She was terrific. I'm doing this now. And part of our weight management solution, we average 5.5% of a person's body weight after 12 months. 5.5% reduction.
Susie?
Yes, I have a question. With regards to the demographics of the Mohave County participants in this program, what age group are most likely to participate in this program? I'm talking about Mohave County employees, not the entire Mohave County population.
Chris?
Sorry, who's that question directed to?
Oh, I don't know. Whoever can answer it.
You,
based
I guess.
Based on the demographics of the Mohave County employees, which age group or which age bracket would participate or is currently participating in the current program that you have for the county?
I don't have that information. Julie, I don't know if you have it as well, and could that possibly be a PHI issue?
Hi,
Julie, you
this
still
is
there?
Missy Jensen. I'm going to jump in. I'm looking at the appendix for Livongo, and I'm seeing on page 99 of the packet, as far as the current program is concerned, 82% of people enrolled in the diabetes management program are the employee, as identified by self.
I don't really think that was the question per se. Did that answer your question, Susie?
No, I'm talking about the age group.
Oh,
for
okay.
The
I
participants of the, of the current participants of the program right now.
Okay. Also on page 99, it does include the age breakdown. It doesn't go by self or employee versus dependent, but it's showing that 14% are 18 to 44, 29% are 45 to 54, 41% are 55 to 64, and obviously whatever's left, I can't see it on the slide here, are 65 plus.
Okay, so basically the 55 and 64 age group is the most is the age of the most of the population that we have for the current program.
Correct.
41%. Okay, thank
That is
you.
correct.
Okay, I have a couple of questions. So this is two parts. We just got the Livongo for the diabetes report, and also whether we took expand to other aspects of wellness health. And so how long is the diabetes program? I've lost track. How long have we had Livongo? 2 or 3 years?
About 2.5 years.
2.5 years. And so in 2.5 years,
Yep.
we have a third participation out of the people who are, can get it. And so if that goes into the other ones, I mean, it's going to be kind of a small amount. I mean, in your history, do you see the percentages going up year to year? I also think we're at sort of a point where this is all done online. Some people just don't want to talk about their health, online and text, not knowing where it's going to go. And I think we're in that age group that maybe the younger people, I think, will be easier for them to do because that's how they brought up. But in our demographic, I think that may be one of the reasons. I'm not sure. But out of that 100 people who can use this service, and it's a good one, have we ever asked why they don't use it other than, they may have pre-diabetes or whatever? I mean, it's free to them, right? And other people are happy with it. What's the disconnect?
So as far as other clients that have implemented diabetes management programs, I've seen, and Erin, please chime in as well. So I've seen pretty consistent membership. So we'll see higher engagement usually in the beginning, and then things level off a little bit. But generally, I'm seeing between 30 and 40% when there's not an additional incentive applied. So any kind of chronic condition management program will usually see about 30%. So as far as enrollment for the current program, it's been pretty steady since the program was implemented. And from the first year, we did see obviously increasing engagement, but now I definitely agree it's leveled off, but it's comparable to what I've seen with other clients who have implemented a chronic condition program. Erin, did you have anything else you wanted to add there with your experience with some of our other clients?
Yeah, I would, Missy. Thank you. So, Madam Chair, Missy's right on. Basically, 30% is pretty much normal, and there's a variety of reasons from indifference to technology to whatever. I will say that we've migrated these programs over the years onto these online platforms because the data is so much more reliable and so much more extensive. It's real time. The meters it's tied in, it compiles. The old school stuff was basically a one-on-one in-person meeting with a pharmacist where you're doing paper logs. So the data that you get from these programs, regardless of vendor, is so much better. We do have a client, it's a 6-county consortium that we run, that has just over 60% participation in the diabetes program. It followed the same trajectory. It took about 5 years to get there. But in their case, the initial focus was just diabetes because these expansion programs weren't there. And we did a copay waiver for diabetic medications and supplies, and that inducement got us to 60%, and that's where we leveled out. So what I would tell you is not to be discouraged by the 30% without an incentive. This is not an advocacy for an incentive, but that 30% is a 100% afflicted population. So this is not the shotgun approach where you test everybody. This 100% of those numbers of people have the condition, they're getting coaching, and they are more likely to take their medications and other preventative and controlling activities because of it. So you've hit it. You got a target-rich environment. You are hitting it. You would just like to get a higher percentage involved.
And I have one more question. So on the Livongo platform and the expansion, so you have diabetes, dyslipid, whatever that is. What is that?
Dyslipidemia is cholesterol.
Oh, okay.
Management.
Hypertension, which is all you can quantify that. It goes up, it goes down. Behavioral health is a different thing. So I'm trying to understand what the service is for behavioral health. They get to, rate their mood. I'm just a little confused.
I'll jump in from our side.
Well, first of all, there's an assessment.
I'll jump in from ECA's side, then I'll defer to Livongo. In general, in the practice, and Missy talked about this at the beginning, what we see with chronic disease and also with the other serious medical conditions unrelated to chronic disease is that they come in clusters. So speaking to diabetes specifically, you're going to get cholesterol lowering medications, and then there's a chance you're going to get blood pressure lowering medications. We refer to it internally as the Gordian knot because it's not just one expensive condition, it's multiples, and they play off each other, and you're trying to hit it for multiple points to control it. That's what's going on. The missing piece throughout my career has been the mental health component, because with this, we know that the incidence of depression with diabetes and some of those other comorbidities is much higher. So this is trying to integrate that same thing with mental health. And I'll just tell you as a side note that with the EAP providers and with nurse case management across our practice, what we have done is make sure those nurse case managers also have access to the mental health side so that when they have people with cancer, cardiac, major surgeries, they're handing them a brochure, if you will, for support for them and their family. So this is actually a very good development in my mind, that they're not just focusing on the measurable parts of the A1C, but the emotional health and well-being of the patient and their supporting family. I think it's an excellent addition to all of these programs.
Okay, you know, I'm a big advocate for mental health services, which we don't have in this county. And so any little bit, I think, is a good thing. I was just trying to kind of understand how that works on your platform. So, all right, any other questions? Okay, thank you. Move on now to
Thank
the
you.
next part. Erin?
Madam Chair, Livongo, you have basically 1 minute to do a wrap before we move on.
Chris, should I hand that over to you? Do you want to take that?
Yeah, I think that, the one thing we'll mention, Aaron, you kind of said it earlier, is that, behavioral health is oftentimes, looked aside as, do I really have a problem? Who do I call? What do I do? Will I be discriminated against? Well, what we found is that it is very, prevalent today. And that's why, Livongo, over the years, we've acquired best-in-class acquisitions, and we acquired MyStrength back in 2019. And with that, they were the leaders in digital behavioral health, and they actually brought us, 1,200 clients and 150,000 members. So the whole idea behind the whole person solution is to address all the chronic conditions a person may have, not just one. I can tell you right now that with the 51 members that are currently utilizing the diabetes management program, based on our book of business, 29 of them probably have hypertension as well. So they kind of go hand in hand, and we're here to try to help them get to a better place.
Okay. Anything else? Anyone? Yeah. Okay, so now we move on to OMADA. Is that how you say it? OMADA program proposal.
Okay, thank you, everybody.
Thank you very much. Have a great day.
Yeah, thank you.
too.
Yeah, hey everybody, this is Adam joining from OMADA Health. Thank you so much for having me.
Thank you.
So, Missy, did you have any lead-in that you wanted to give, or should I just kind of kick off here?
No, please go right ahead and proceed. Aaron will be keeping time just as an FYI, so you do have 30 minutes.
Okay, awesome. Well, I know that, I wish I could be there in person, and it's kind of hard to have a greater conversation with this call-in method, but I'll try to make this as kind of clear for everybody as possible here. What I'm going to walk you through is OMADA Health and what we do and what we're proposing to do for Mojave County. So please, just flag to Missy or let me know if there are any questions as we go through here. I want to make sure that I'm making this clear and relevant for everybody. I'm going to call out two things as we go through here in regards to things that I want you to really remember and take away from this. So I'm going to give you a number of details, but there are two things that are kind of important for you to just remember in terms of what does OMADA do, what is our brand in the marketplace, and what are we bringing that's unique. So on the title slide here, you can see we're talking about proactive care. That's one of these things. So when you think about OMADA, I want you to remember that what we do and the way that we've structured our program is to be proactive with our members. We don't want this to be a benefit that they enroll in, that they have, and that they need to use. We want this to be a benefit that they have and where we're actually working to engage them to understand what can we do that's going to be helpful for them, what is the care plan that we want to agree with them on, what is something that they think is reasonable for them, right, and sustainable, and we want to achieve better health with our participants by working with them, by engaging them in conversation and making sure that they stay engaged with what we're doing. So I'm going to go ahead and skip slide 113. I think for anybody that wants to read a little bit more about, our success in the market and so on, I would recommend you check out our website. We are definitely one of the leaders in this space. We were the first digital healthcare company to receive a partnership from the American Medical Association. We were the first digital healthcare company to publish successful peer-reviewed results for the programs that we have. And we were also the first company to have the fully integrated continuous glucose monitors. I'll talk about those in more detail in a second for those of you that aren't familiar with that kind of technology. But, we've had a lot of firsts in the market that we're really proud of, and definitely something you can read about more online here. So skipping down to page 114 for everybody, this is what Omada does. And what you're looking at here, these 5 programs cover your top 5 chronic conditions, or what we know around the world and in the United States. Everybody's medical spend is primarily being driven by these 5 things. So prevention, this includes people who are in a high-risk category, high BMI, high risk for these chronic conditions, diabetes, both type 1 and type 2, hypertension, behavioral health conditions, and musculoskeletal. So what I'm going to focus on today is prevention, diabetes, and hypertension programs. But just so you know for future reference, Omada does do other things, and we know that all of these things are overlapping and have a major impact on cost. So for example, you might think that people with diabetes who are in the most advanced stages of the disease are going to be your most expensive claimants. And to some extent they are. But actually, the most expensive folks in your population that have diabetes are the ones that also have depression. We know from research that's been done that someone with diabetes and depression, it has a 4.5 times higher medical spend than someone with diabetes alone, even if that form of diabetes is advanced. So these comorbidities, as we call them, is something to think about. And all of these things that we're looking at addressing with people are overlapping and have things to do with each other. If we go down to slide 115, this is the second thing I want to call out that is important for you to remember about what does Omada do, what is unique to what we bring to this space. So the first thing is proactive care. The second thing is real human health coaching with no AI. So a lot of our competitors talk about real human health coaching. A lot of our competitors talk about real human touch. But with Omada, there is no artificial intelligence interface. No one's ever talking to a robot. So all of the messages that they have coming inbound to them, all the conversations that we're starting with them, that's a real human being that they're working with. And we utilize a care team model. So, for example, someone with diabetes is going to be working directly with a health coach and a certified diabetes educator, or what used to be called a certified diabetes educator. And those people are going to be collaborating and coordinating on this person's care. So diabetes is and hypertension, they're both really complicated conditions to manage on a day-to-day basis. You've got so many things that you need to keep on top of, including, things that you need to do on a yearly basis, like eye exams, foot exams. We want to provide a program that allows people to externalize and export that care to somebody else who's a professional. So we check in with our participants every single year and make sure that they're getting those things done. We keep track of who's done those things when. And so we can actually be, again, getting back to proactive, we can be the proactive force in someone's life saying, hey, we saw that you haven't been in for an eye exam this year. That's really important for you to do with diabetes. So we want to encourage you to do that. We want to enable you to do that. And we're going to check in with you regularly until that's done, just to make sure that that's something that you're keeping on top of for your own health. And that is not the way that the regular healthcare system is set up, right? No doctor is calling their patient and saying, hey, I haven't seen you in a couple years. I know you have diabetes. It's important that we come in and get some of this stuff done. But Omada can do that, and the care team model is set up to achieve that kind of thing. And we know that this is really important to people, and I'll touch more on this in a moment. So if we go down to slide 116, and actually before I do, I'll do a quick pause just in case anyone has, I know I'm whizzing through here and talking a lot, but are there any questions that anybody has? I'll do a quick pause.
Any questions? Susie?
No question.
Okay, thank you. You can continue.
Okay. So this is just kind of a practical note here. You know, we have all of the most cutting edge devices that you're going to see in the marketplace. So everybody in our program, getting back to a personalized experience and a personalized care plan, they're going to get the devices that are relevant for them. So for example, someone with who goes into our prevention program who needs to be thinking about their weight primarily, they're going to get a cellular connected scale to track that weight. Someone who's in our diabetes program who doesn't have a high BMI, like, for example, many people, we know high BMI is highly correlated with type 2 diabetes, but many people with type 1 diabetes don't have that issue. So in that case where high BMI is not a problem, we won't need to give the scale to somebody. And that saves the county money because we're not rolling out that device to someone that doesn't need it. But if someone does have diabetes and hypertension, let's say, and high BMI, then they'll get the scale, they'll get the glucose meter, and they'll get the blood pressure cuff. So folks are getting what they need. And if we jump down to page 117, this is where we're looking at the CGM. So I know that there tends to be a spectrum of folks in the room and their familiarity with this device, but essentially, if you think of the way that you think of someone with diabetes typically testing their blood glucose, it's the thing where they prick their finger, they squeeze a little drop of blood out, and then they have a glucose meter, a blood glucose meter, that they use to absorb a little drop of that blood and see something about their blood glucose levels. So the way to think about it is that is like taking a picture of your blood glucose. You only know what it is in that exact moment. You don't know if it's going up, you don't know is it going down, you really don't have any context, but you know what it is at that moment. And you have to prick your finger. So what a CGM does is it's a patch that you put on your arm. You don't have to take it off for 2 weeks. It can stay on in the shower. It's not painful, anything like that. And all you need to do is swipe your phone over it, and it'll take a glucose reading. And that allows you to take a reading much, much more often than you would with a prick your finger method. And so because you have so much data coming in through this sensor, you have more of a movie with your blood glucose. So I know what is the trend that's happening. I know what is, how is this affected by the grape that I just ate? How is this affected by the walk that I just took? And what's really cool is that these devices would typically only ever be prescribed to people who have type 1 diabetes through a health plan. In fact, I don't know of any health plan that prescribes these for type 2 diabetes because it's just not a clinical use case. However, in our program, we give those out to everybody, and that's totally included in your cost. It's nothing additional for any participants, of course, who would never see any cost from us or for the county. This is something that we want, an experience that we want them to have. And the way that it was explained to me that I think makes a lot of sense is these devices allow someone to, it's like making their body clear, where everything that they do, every action that they take, they're seeing how that impacts their glucose levels. And that's incredibly powerful for people. And of course, it gives us a lot of data when it comes to coaching. We can see how their body reacts to certain stimulus, as individuals. If we go down to 118, you're just seeing a couple screenshots of what our user interface looks like, what the CGM integration looks like. It's super, super easy to set up, and that's what that looks like. Coming down to 119, so we are keenly interested in what is the most effective way to engage people. Typically, you've got a group of people, you're going to see about 60 to 70% of folks with diabetes and hypertension where those conditions are unmanaged. So what are we really doing differently that's going to turn this around in terms of someone's engagement with their health and someone's ability to manage their condition? Well, we've looked at what doesn't work. I'm going to show you what does work in a second. We know that when someone is only engaged with their device, when you're only encouraging them to, for example, track their steps with a pedometer, or you're just encouraging them to use their device for home monitoring for diabetes, you're much more likely to have this person churn over time. And we can actually look in our participants and see who is sending up red flags that this person is likely to not stay engaged for very long. And we have strategies that we're going to employ to make sure that we stop that person from churning before that they do. So that's something we want to look out for, is people who are only using a device, only doing monitoring. The second thing is we've seen, or the next two things are, we've seen that the more automated things are, the less engagement you're going to get. So if someone gets, and we can all think about this as, you know, people who use these cell phones and things ourselves, if I receive a push notification from an app or I receive an automated message, that's not something that's going to be very compelling for me. And that's something that is actually, I'm more likely to, you know, turn it off over time. Whereas when I get a text message from a friend or a colleague, I'm likely to read it and likely to respond. And so that leads us down into page 120 of what does work, and that is human-to-human connection. So we know that if we can get members to send messages to their health coach, that's one of the things that is going to be a high predictor for success in our program. We know that coaches are much, much more successful at re-engaging people than automated nudges or automated push notifications. Basically, the extent to which real human beings are involved in the care, the extent to which real human beings are doing the conversations, that is going to be a major predictor for how good are we at engaging people, keeping people from churning, and ultimately creating some behavior change and creating some health changes down the road. So the remainder of the slides in this presentation, I think, are really important for you to see. Omada is committed to providing real studies and real outcomes and supporting the ROI that we're projecting for the county using real data. We actually recently concluded with the University of Nebraska the largest randomized control trial of its kind that's ever been done on a diabetes prevention program. We were really proud to see the outcomes that came out of that. We were actually not comparing the Omada program versus people who had not gone through a program. We were comparing the Omada program and Omada participants to people who had gone through an in-person diabetes prevention program, which has historically been the gold standard. Basically, in-person programs, there are a lot of barriers to people getting in there, right? You've got to have people go into community centers and so on. And so digital has some distinct advantages, and especially now during the pandemic. But historically, in the scientific community, if someone was able to make it into an in-person program, that was kind of considered to be the best. That was where the best outcomes lived. We've actually shown that not only is digital more convenient for people, but in the Omada program, we're capable of delivering even better results than compared to in-person programs, which was fantastic. And this is a little overview of that study there. We'll actually skip down to a couple slides down to slide 123. And I just want you to see this because and I know that this is really getting into the weeds here, but when we talk about Omada as a clinical program, one of the things that I really want to flag to all of you is that the reason you have a diabetes program is not just to be able to say you had one, right? This is because you're looking to really make an impact in health, you're looking to make an impact in your claims. And so what is going to deliver that impact in the long term are changes in real A1C levels. What you're seeing is a comparison between Omada's results for real A1C and Omada's, one of our big competitors that you might be familiar with, who's in the same space. And what we know is in that our studies, we can show a real A1C reduction of greater than one full percentage point. And with our competitor in this space, they're showing no change. And so these are the kinds of clinical details that are, take a keen eye when you're looking into the research. But this is something that Omada is really focused on. And we know that the program that we're bringing and that the care that we're delivering has a real result for people. And we know that that's important, of course, in people's health and ROI in the long term. So I think I'm just about at time here with about 60 seconds left. Are there any questions on what we've gone through, or things that I can briefly speak about a little bit more?
Any questions
Chairman?
for the presentation?
Madam Chairman, I have a question.
Yes,
This is
Susie.
Yes, it seems like you pride yourself in your ability to reach out to people to participate in your program. Based in your industry or your programs that you have around, what is the percentage of people that participate in your program based on the population that has these chronic diseases?
Yeah, good question. So that is going to be, we tend to give a range, and that range tends to be between 5 and 10% per condition in terms of what we can enroll, and that'll be due to a number of factors, right? Due like what percentage of your population do you have email coverage for, and the strategies that we're going to employ to reach them. But you're right, that is something we pride ourselves on, and a big, I think something that's going to be helpful for you is you will have a dedicated customer success manager with Omada, and that person's expertise and that person's role is to work with you to be very dynamic in the way that we think about doing a marketing campaign. So we're going to come to you and we're going to say, here are our best practices. Here's what we know from the data we've been successful with. But we also want to learn from you. What have you done that's successful in the past, and so on. And we want to be flexible. We don't want to, give you one marketing campaign and that's it. We're going to work with you continuously to hit those numbers that we want to hit. And if we don't hit them, we're going to work with you. We're going to adjust, and we're going to make sure that we employ a different strategy going forward. So in quick answer to your question, just to recap, about 5 to 10% per condition, and we're going to push to have that on the highest end of the range over time as we learn about what works.
Okay.
Does that answer your question, Susie?
Yes.
Okay, thank you. Any other questions?
Oh, I have another question to Aaron Collins. Aaron, if a trust, sorry, am I okay?
Yeah, you're okay, Susie. I just turned on the mic.
Okay. All right. Seemingly there are two providers for this service now. We're currently in one of them, and here's another provider. How is the rollover to another provider? What pros and cons do we see in rolling over to a new provider?
May I
in terms
interject
of
here, Susie?
Sure.
I think this is a question for when we go into it. This is just
Okay,
for
all
the
right.
presentation.
Okay,
We'll ask that question later because it's my question as
All
well. I'm
right.
sure everybody here. Thank you.
Yeah, I can really quickly speak to that from our part. I know a little bit about your situation from Aaron and his team, and I can tell you that you would not be the first group to make a switch from one provider to another. So we actually do have some specific resources and some specific tactics that we would employ to make that transition really easy for people. We know if somebody is in a current program, let's say for diabetes, and they like it, they're using it. If a new program is rolled out, we want to make sure that they don't feel like that change is too sudden. We want to be very clear in saying, hey, this is, the features that you like about your current program. This is that counterpart in our program. This is how that works. We want this to be a warm transfer from the pre-existing program to our program. So we'll make sure that we're keeping that transition for folks in mind.
Thank you very much. Okay. Time to move on? Great. We have the next one up on the line for our prescription drug utilization. No, I'm sorry, Blue Cross Blue Shield of Arizona. Overview, discount, and utilization review.
Good morning, Madam Chair and trustees. This is Rachel Martin from Blue Cross Blue Shield of Arizona, and good morning to the Aaron Collins team, which I was there.
Hey, Rachel, you're really light. We need you to speak up.
All right, how's this? Is this better?
Yes.
Okay, great. Well, good morning, everyone. So I am going to be referring to page 151 within your packet. And I've got plenty of slides, but I know we're on a very tight time crunch. So I will just highlight a few of the annual touch points for you guys. So One thing I wanted to call to your attention is the data that is in the deck as well as the executive summary is for December 1st, 2019 through November 30th, 2020. So there's a month variance there between my data and Rick's data. But here is a few of those highlights that I want to mention. So for this 12-month period, the Blue Cross Network has generated Mojave County a 56.1% annual savings to your claims. That represents $13,164,164 in savings to the trust. Now, for every percentage point that we have in that 56.1, every 1% of that medical discount with our providers in the facilities and providers, PCPs, specialists, etc., represents about $235,000. So if we were to select a different network, we would be leaving $235,000 on the table if you chose a different network outside the Blues. Moving to the second point. So what I was doing was looking at your utilization from the claims that we received from Meritain, and I wanted to see what is the service category that is driving your highest savings and your highest utilization. And when we say in the insurance business, service category, it would be inpatient, outpatient, and professional services. So for Mojave County in this 12-month period, outpatient services drove your highest savings of that $13 million. So when I represented the $13 million for annual savings to the trust, 47% of your outpatient claims represented $6.2 million in savings for the trust. That I also took it a step deeper to see, okay, for all of the claims that we received from Meritain, what's the cut on that spend? So 15% of the claims came in as an outpatient claim, and that represented 15% of your claim population. Now, one thing I noticed too, so outpatient services drove your highest savings. However, the discount was only represented 50%. This is a decrease from last year, and I would need to work with Rick to learn a little bit more on those provider types for me to do a little bit more deeper dive as to the why. But that, when I'm looking at your year-over-year statistics that you'll see in number 5, we did have a little bit of a decrease for your aggregate discount achieved, and it was driven by outpatient services. Moving on to number 3, I wanted to share with you, so of all the claims in those service categories, inpatient, outpatient, and professional, what was the highest utilized? And for your population, we had professional claims come in that represented 84% of the claims that came in, and that generated $4 million in savings to the trust. You'll see here the professional discount that we have for the trust equaled a 64% discount, which is pretty representative from last year to this year. The number 4 is just our renewal access fee. So we are in the last year of our multi-year agreement, and our rate will increase to $17.75 to tap into the Arizona Blue Cross Blue Shield network for July 1st. Now, I took a very high-level historical claim summary for you guys here. I would like to reference, if you jump to page 162 in your presentation, this gives you much more detail on that historical claims trend for 2018, 19, and 20 for the county. And you can see here, the outlier for me is seeing that outpatient savings is where we dropped a bit, but that's driven by the providers that are used in that setting, which I'd like to dig a little bit more deeper on that to find out who. And then lastly, I'll jump back to page 151 and just share with you folks back to 5, the claim savings has been pretty representative over the past couple of years. We did have the increase in membership, which would, in 2020, which would reflect the increases in the claim savings for 20, the claim savings per contract per month, and of course the membership count. The discount achieved, again, we lost a couple points there, but I think that's driven by 2021, the low utilization due to COVID, and 2, there's just some outpatient services where I'd like to dig a little bit deeper and find out where those services are being done. Now, the last part for me is to share with you, and I think last year as well, we shared that we were moving to a new platform for our billing and membership. So with COVID and the rest of the world, we kind of pivoted to putting our resources in helping Arizonians in the midst of the COVID pandemic. So with that shift, we have delayed our system migration to next year. Now, within the deck on pages 151 through 171, you will see a slicing and dicing of all of this high-level executive summary I put together for you on page 151, and I'm happy to address any questions.
Are there any questions? For Rochelle? Is that how you say your name?
It's Rachel.
Rachel. Any questions? No questions, Rachel.
Okay, guys, thank you so much. Enjoy the rest of your day.
Thank you. Okay, next up is prescription drug utilization, Lisa Thompson and Carla Anderson from Navitas.
Yes, we are on. Let's just do an audio check. Can you hear me? This is Lisa.
We can hear you.
Okay, Carla, you just want to check real quick? Yep, can you hear me?
Loud and clear.
Perfect.
Excellent.
Okay. So this is Lisa Thompson. I'm a National Account Executive with Navitas. And joining me is Carla Anderson. She's your Senior Clinical Account Executive. And we're going to report on the prescription or pharmacy spend for the trust. And so our section starts on your red numbers 172. So on that, that's just a transmittal with an overview. So let's just go right into the presentation. If you go to your red page 175, you should see a slide that says overview. Everybody else set there? Am I good to continue?
175?
Yeah, 175, and it should say overview at the top.
Very good. Everyone okay?
Okay.
You can go ahead.
All right, sounds good. Thank you. So the comparing period we're using here, if you look at the bottom, is the second half of 2020, so 7/1/2020 to 12/31 to coincide with the plan year, compared to the second half of 2019. So when we look at those time periods, the plan paid was $885,607 for the second half of 2020, and it was an increase of 5.5% over the prior time period. The plan paid per member per month was $69.35, which was a small decrease. And when you compare that to our book of business, it was well below our book of business, which is at $124.06. Your generic dispensing rate was 85.2%, which is very similar to the prior time frame and very similar to our book of business. And that last bullet point, the specialty percentage of plan paid was 32.3%. And we compare that to our book of business, but that's kind of subjective because specialty drugs are those expensive drugs used to treat chronic conditions, and those can fluctuate. So let's go to your page 176. And this slide lays out very nicely your costs for the time period. So we look at that current period and look at the bottom half of the slide, if you would. and that's your AWP, or average wholesale price cost, with dispensing fees and tax. So that's what we pay the pharmacies. That was $2,422,000. You add in the administrative fees, so the fees paid to Navitus, $28,224, and then you subtract out the network discount. So that's the benefit of Navitus contracting with pharmacies on your behalf, and that subtracts out $1,337,000 from the trend. You subtract out the member paid of $131,634, and you subtract out the other payer amount of $67,560, which is coordination of benefits, other payers paying primary. So that gives you an overall pharmacy benefit cost for the time period of $913,831, and overall pharmacy benefit cost per member per month of $71.56. So this is just the only slide that includes the administrative fee into the factor. Okay?
Excuse me, I have a quick question. I'm sorry if I didn't understand or hear you. The other payer amount from previous period was 0, and then the current period 60. What does that mean? 67,560.
That means for the time period before, there was no claims that had other payer paying as primary. There was no coordination of benefit. So in the second half of 2020, we did see other payers paying primary and picking up parts of the cost of those prescriptions as a primary.
Is that unusual activity?
It's not unusual. If you all expected that there should have been coordination benefit in the second half of 2019, we could go look at that, if that's something you're used to seeing.
Okay. I'm just curious.
Yeah, it just depends on the membership and if they had coordination, other coverage is primary.
Okay.
All righty. So if we go to your slide or page 177, we look a little bit at the trend. So as I mentioned, that plan K did increase, and if you look at the lower right-hand slide, part of the slide, your utilization increased by 10.9%. So that's really where any of the increases were. Everything else was a negative or a decrease to your pharmacy spend. And then if you look at the left-hand side, this just breaks down a little bit your overall trends of specialty and non-specialty. So specialty are, as I mentioned, those expensive drugs used for chronic conditions. That was the majority of the spend was in specialty. And if you go to your number 178, we're just going to dive a little bit into that utilization number. So look at the bottom half of that slide, and you can see the increase is due to your utilizing members increase. So you had 1,125 utilizing members, which increased by 6.4%. Your average invoice membership also increased by 5.9%. And then if you look at that last line, the day supply per member per month, the amount that the members were filling per day, it also increased by 10.9%. So that's where the increases really were. You just had more members utilizing more medications, more days supply. And Carla, I'll turn it over to you.
Great. Thanks, Lisa. So I am going to jump in, and I have some good news. I have some savings that I'll talk to you about right now. So there's two programs that we have for savings for your plan, and the first one is post-patent rebates. So those are medications that once the product goes generic, we have really good opportunities from the drug manufacturer to get rebates for our clients. So this slide 179 is showing the different products that have rebates, and it's a total of $21,515 that the plan got back for utilizing the post-patent rebates. All right. The next slide is looking at your copay max savings. So that is another program that we started last year, and it's mostly specialty, but it is allowing for maximizing of copay assistance programs. So the savings here was $62,700. That was definitely, hopefully, a worthwhile program that you signed up for. So we're very happy to give you that news. All right, moving on to slide 181. I'm just talking a little bit about generic versus the brand, and Lisa already kind of alluded to that you guys do a really great job of utilizing generic products with an 85.2% compared to the book of business of 85.3%. So very, very much doing well with that. Next slide is slide 182. This slide is looking at the difference between the script cost and the script volume. So looking at the left-hand side of the document first, it's 71.5% of claims fall into this category of claims less than $25. And that accounts for 2.4% of overall plan paid. On the other side, the claims that are greater than $1,000, these can be specialty medications as well as we see a lot of 90-day supply of diabetic products in this category. Claims greater than $1,000 makes up 2.6% of overall volume of prescriptions. But it also makes up 60.6% of total plan paid. So that's where the big chunk of your prescriptions are lying. Next slide is 183. And this is just looking at the top categories by plan paid. The last comparison period we had was very similar. So anti-diabetics, anti-neoplastics, which are oncology medications, and then the analgesic anti-inflammatories, which are the rheumatoid arthritis or psoriasis type medications. So that's where we're seeing pretty consistent within the last year as well, comparison. Slide 184 is looking at the top drugs by plan paid. So just to call out, 3 of these are specialty medications, which would be Humira, Ibrance, and Dexel, which are on the top. And then the other 5 actually are diabetes medications, and then there's a couple asthma medications, cholesterol medications. So nothing that jumps out, very consistent with your previous utilization as well. Slide 185 is looking at top categories by script count. I won't spend too much time on this one. Just to note, the antidepressant category did go up a little bit in this comparison period. But antihypertensives and anti-diabetics remain up in the top 3 categories as well. So slide 186 is top drugs by script count. Again, I won't spend too much time on this. These are kind of the everyday maintenance medications, including cholesterol, hypertension, and thyroid medication. So again, nothing unusual about the data here. Next slide is slide 187, and these are just a little bit about the therapeutic categories. So I won't spend too much time, but just to familiarize you with these slides, these are the anti-diabetic category, and under the percentage of plan paid, that gives the total plan paid percentage. So for anti-diabetics, it was 30.2% of overall plan paid that was in the anti-diabetic category. The main drivers in that category are Trulicity and Lantus. So those are obviously diabetic medication. Slide 188 is another therapeutic category with the oncology medications. Those accounted for 16.5% of total plan paid, and Ibrance and Sprycel were the main drivers in that category. So moving to 189, again, one more therapeutic category, the analgesic anti-inflammatories. That was 10.7% of overall plan paid, and Humira was the main driver in that. And Humira is used for arthritis and other anti-inflammatory conditions. So slide 190, just to provide a little reminder that Navitus is regularly monitoring for opioids and utilization. Any utilization, anything that pops out on either a concurrent DUR, which those are the real-time messagings that we send the local pharmacy. And then also retrospectively, we go back and monitor and look at all of your members' medication profiles, making sure that there's unusual about utilization in those members as well. So there was a little bit of an hydrocodone utilization, but that was kind of consistent as well with the increase in the oncology that we saw during this comparison period. So slide 191 is a little more another kind of look at the opioid utilization. We have the short-acting on the left-hand side, and on the right-hand side, the long-acting products. And again, this looks very consistent with our book of business, and there's really no red flags with utilization here.
Hey, Carla, this is Aaron. You got about 2 minutes for wrap.
Oh, okay. I can wrap up very quickly. The last slide I'll touch on is the top specialty conditions, and again, that's oral chemotherapy and also chronic inflammatory. And then I am going to hand it over to Lisa at slide 195 for her to wrap up.
Yep, thanks, Carla. And just real quickly, that just shows by the percentage of plan paid what channels or where most of the utilization is. And you can see on that pie chart on the left, it's mostly at retail. And then the percentage of day supply, which we talked about, had increased. And that's really your retail extended day supply, which is 90 days at retail. And the last two slides are just showing you some generic and brand price changes that occurred in the time period. And we are all set then.
Okay. Are there any questions? Then thank you very much.
Thank you.
Thank you all.
Okay, next we have dental claim reviews. Ann Copeland from Delta Dental.
Good morning, everybody. I hope all is well over in your area. And I'm just going to spend a couple minutes going over your period January through December 31st of 2020. Just a brief explanation on slide 199. It just shows that the core plan overall savings per employee per month was $30.30, and the buy-up plan overall net savings was $49.85. So hopping over to slide 201, here are some highlights for the core plan. 51.3% of your claims were concentrated in preventive and diagnostic. This is fairly high compared to our book of business. We usually see it running about 39 to 40%. So kudos to Misty. Hopefully her efforts for the dental cleaning wellness initiative is, coming into fruition. The average claim payment was $118 compared to your previous year, $113. And then your utilization rate, which measures the average claim, was 2.17 per subscriber compared to the prior year, 2.4. But when you look at the per member utilization rate, that's every single person insured, was 1.15 compared to last year, 1.23. 97.4% of your procedures were done by Delta Dental Dentists, so we are pretty happy with those results. Want to make sure that we have a lot of network access points for everybody that's in the plan. And then your savings cost containment tools, will go into that a couple slides down. The number of patients using your plan was 323, or 54% of all members. The prior period, it was up a little bit, 325 or 60%. The turnover in your plan, we don't really pay too much attention to because it could be somebody moving from one plan to the other, or some changes and so forth. The 0.6% of your members met or exceeded the annual maximum benefit. Kind of during this benefit accumulation period. And we're not really too concerned with that because we think that you have an adequate benefit package that you offer to the employees of Mojave. And then, again, on slide 202, your overall net savings on the core plan in 2019 was 67.5, moved up in 2020 to 70%. So we were pleased about those results. Slide 203, this is a review of your buyout plan. In this one, this 39% of paid claims were concentrated in preventive and diagnostics, so that's pretty standard what we see across the board in our book of business. Your average claim payment was $174 compared to the previous year, $180, down just a little bit. The utilization rate did go down a little bit as well, was 3.64 per subscriber compared to the previous year, 4.11, or your per member utilization was 1.53 compared to 1.75. 97.3% of your procedures were done by Delta Dental Dentists. And again, we'll go over those cost management tools in a couple slides down. The number of patients using the plan on the buyout plan was over 1,000, representing 66.8. In the prior period, it was a little bit over 1,100, representing 71.7. And then again, barely any members met or exceeded their annual maximum benefit. We think that utilization is kind of a reflection of, obviously, COVID during this time period that was in review. And on slide 204, your overall net savings for the buyout plan in 2019 was 59.8, but bumped up a little bit in 2020 to 60.2. So I wanted to just kind of give you a little explanation about the dental offices. I'm sure you were all aware when COVID happened, like everything pretty much shut down. And what we noticed is after doing some surveys, when the dental offices did open back up, some of them it was May, some of them it was June, we just wanted to try to provide you some statistics with surveying over 2,000 dentists. And moving into slide 207, what we wanted to do is we wanted to make sure that there are a few precautions that some dental offices are taking, and we wanted to make all of our members aware of that. So here's just some little bullet points. of what had transpired during the whole COVID, which is still in force. Moving forward to slide 208. When the dentist opens, well, I think that's just a duplicate slide. My apologies. So moving on to slide 209, your highlights of the plan. Oh, my goodness. So it's in here twice. That's kind of interesting. Okay. So the claims by coverage category in the core plans on slide 211, it shows you basically, if you look down below at the pie chart, you're going to see that it stayed pretty much the same as far as the orange colored pie, piece of the pie was diagnostic, the kind of teal color was preventive, and routine fillings. I did notice that fillings did go down substantially from 14% down to 8%. And again, that could have been, some of the results of COVID, dentists really just kind of doing cleanings and exams or maybe emergency treatments, but then maybe has kind of go back into full course of any types of treatments thereafter June. On the buy-up plan, the same thing, your preventive and diagnostic kind of stayed the same, was just up a little bit in 2020 compared to 2019. And then this is interesting, your routine fillings went down in this particular plan, but that was only by maybe 4%. So moving on to slide 213, these are the dentist selection patterns for the core plan. And just to share with you that 92% of those claims that were processed were related to our Delta Dental PPO network, and 6% of those were related to our Delta Dental Premier network, which is representing about 24 claims. What we like to share is that a Delta Dental Premier dentist is exclusive to Delta Dental. They typically do not accept other insurances, and their discounts are not as steep as a PPO provider. But had you been with any other carrier, they would be considered basically out-of-network claims. So we're happy that we can offer the PPO Plus Premier network. It just gives you a lot more access points as well as access points throughout the United States. Moving on to slide 214. This is kind of just a summary of where your savings occurred by the PPO providers. I mentioned that they offer deeper discounts. So if you look at the preventive and diagnostic, you saved over 41.4%. And your basic services is about 37.9, major services 34.7. So your overall savings was about 37.6, and those were for people that use the PPO providers. The dentist selection pattern report on slide 215 shows the buy-up plan, and 84% of those claims that were processed were done by a PPO provider. So again, that's where you receive your deepest discounts. And then 230 or 13% of those claims were done by a premier dentist. So again, those dentists would be considered out of network had you been with any other carrier. Now, interestingly enough, this particular plan shows that 60 claims, or about 3%, were done by non-network providers. And we find very little utilization in the out-of-network providers because our network is so large. But we do know that there are some dentists that just don't accept insurance, period. They don't need to. Or we find that some of the members choose to go out of the country, or maybe they're traveling and they had to get some work done while they were out of the country. But we do offer the Delta Dental directory to every state in the United States. So moving into slide 216, we show that your PPO savings for the buy-up plan Your preventive and diagnostic represented about 41%. Your basic services, 39.9%. And your major services, 29.3%. Ortho was sitting there about 6.9%. We don't typically have too much conversations with regards to that because most of the time you're exceeding your lifetime maximum and you don't see as steep discounts. Just a little bit here, as you can see by the submitted base versus the approved amount. So it did give you a little bit of savings. Your overall savings was 33.3%. And then moving into slide 217, this is going to be a kind of like a directory or a definition page of what we're going to go review in the cost management savings reports. So you can always refer back to that when you look at each one of the line items if you want to just see what that is in reference to. But moving into the cost management savings report on page 218, you can see that there's like a 3-year snapshot of the savings that incurred. And if you look at the very bottom line, your overall net savings was 26.5% or $71,000. In 2019, it was a little bit higher, 30%. And then in 2018, it was a little bit higher, and that was 27.9. Now, again, I think a lot of this that we're going to see for a lot of the client meetings that I do and the reports that I run, when we look at 2020 as a whole year, we do find that our claims volume did decrease during the COVID months and then kind of steadily went up, and it's still taking a little bit of time for it to go up. I do know that we have an excessive amount of claims coming in the door now. I think that people were a little more hesitant to go back to the dental office and were trying to just do anything that was necessary or needed, and they still are a little bit hesitant. So with that, I wanted to share that if you look at your cost management savings, the gray bar, and you go about 5 lines down, you're going to see a title that says non-billable procedures, which was over 17,123, representing about 6.3% of the bill charges. Now, in this particular non-billable procedures, we also have included charges for PPE, personal protective equipment. And Delta Dental, during the whole COVID crisis, for a certain amount of time, did elect to offer the dental offices to submit an invoice to us to say that they saw, for an example, 12 Delta Dental patients on such day, that they would get a like $10 fee for each one of those. Those were monies that were contributed by our foundation and by Delta Dental that did not impact any of our clients. So we now and have been not allowing the dental offices to charge for PPE. So those non-billable procedures are do include that particular procedure. And just to take note, we do know that there are some other carriers that do allow that coverage, but we feel that it should not be billed to the member nor to the group, and it should just be a write-off because it's part of their, in a sense, cost of doing business. So I just kind of wanted to point that out to you to let you know that we are on board with all the dental offices, and we have offered different solutions during this whole pandemic. Moving into slide 219, the same thing again. You had an overall savings of 60% on your buy-up plan. It did look like it increased just a little bit compared to the year 2019, which was sitting at 59.8%, and then 2018, 57.1%.
Hey,
So
Ann, this is Aaron. You got 1 minute to wrap.
Okay, thank you. So we did see some significant savings there, and we hope to continue to do so. Just going over the health NTIC reports, we do share these with EAC Gallagher. Missy is aware of them, and we kind of work together to look at your slide 222, for example, your overall behaviors. And this is basically a national benchmark report, just used specifically for us to monitor to see where we can help you improve any type of wellness initiative. So if you look at the little gray box on this dashboard report, you're going to see that 674 members had no visits at all. So again, we try to focus on those, giving them a little more opportunity to try to get out there, do some outreach. I know that you have a program in place, and if they're submitting things, we are doing raffles for electric toothbrushes, which seems to be very well taken, and it has helped a little bit. And moving into slide 223, just to share with you, basically, if you see the little smiley faces, the green, yellow, and red towards the bottom of that slide 223, the no visits, previously 46 of them were serious. And so we don't want them to go to no visits. We want them to move back into moderate. So the same thing with the ones that were in moderate. We want to keep moving these people from healthy behaviors and then positive behaviors. So we might want to do a little more digging on that to see. But when you move into slide 224, you're going to see how we broke it down, that it comes out to about 303 adults that have not seen a dentist in 2 years. And then the cost for not having any visits on slide 225 just kind of gives you an overall picture of how much it costs for those that had no visits versus people that do have a visit. So you're going to see that your claims costs do increase because you're not going to go to the dentist until you have a serious problem. So we want to work with the county to try to change those behaviors. And then just the rest of the slides moving forward, slide 229 kind of explains the whole understanding whole health risks, diabetes, chronic conditions, pregnancy, and so forth. And then the last slide, basically slide 231, is our overall customer service statistics. So those stay pretty steady year after year. We know that we are pretty good with processing eligibility files and printing ID cards, doing our claim audits, and so forth. With that, are there any questions?
Any questions? Trust? Nothing. Thank you so much for that.
Okay, thank you. You're very welcome. Have a wonderful day.
Okay. Next, we go on to the Employee Assistance Program. Carmen de los Reyes.
Hey, everybody. This is Keely Arrington. I'm filling in for Carmen today. She's feeling a bit under the weather, but I'm pleased to be here to go over your Employee Assistance Program. So if you will join me on page 234, we can start diving in. And I'm actually going to go ahead and move to page 235. This is going to give a brief overview of the utilization report. As you'll see here, this is a fairly new program. It started in October 15th. And we've had a utilization rate for the total annualized is 7.32. And for the current period rate is 1.57. I did want to point out that, the past year we have noticed a decline overall in our book of business for utilization. So this is actually looking really, really good. Just because of the COVID pandemic, we've seen more utilization in mental health and substance abuse. So kind of passing through the EAP for more clinical needs, but we're seeing a trend going back towards the EAP at this point for 2021. So I did want to point out that this looks good. If you'll move down to page 236, this is going to highlight our member journey, and I just wanted to briefly go over kind of how members can get connected and the different touch points that are available. So this just points out, an example of a member named Jess, and she's working. She's feeling tired and sad, and so she sees an email from HR that says she has an EAP program available, and a few days pass, and she calls the EAP for help. And then from there, her EAP clinician listens to her, teaches her about some strategies on coping, and she's really encouraged to use local and online resources that are available for free. From there, she makes her own appointment with the local provider and sets up her first session. Then she'll join an online peer support group that's available through the EAP. So the clinician that she spoke with helps her really get connected with that program and how to enroll. Once she's done that, she also engages with some self-guided tools. So that could be through the website and other different areas that the clinician could refer her to. She might need some help with a financial assistant to help with stress. So that will be something a clinician can also refer her to for her free financial consultation. And overall, after all of these different touch points, Jess feels more resilient. So this is just an example of our member journey and how the EAP can step in and really help mitigate some of these stressors that are affecting work performance. For the next slide on page 237, this is just going to touch on some materials that are available. And really what the overview of the plan is, so there's up to 6 face-to-face sessions. Those can be accessed via face-to-face, video, or telephonic. They also have the peer support groups, which is mentioned in the previous slide, the member journey slide. Those groups are fantastic for addiction, depression, bipolar, and anxiety. We're adding new groups all the time. We've just recently added one for parents, and we've also added one for, trying to think of what the new group is. It just was released. It's for first responders, which would be great for this group. The EAP services are great for supervisors as well. We have a lot of supervisors call in with formal referrals for their employees. These formal referrals do not count against the employees' EAP sessions, but they do keep them informed on their progress so they can get back to work in a more productive way. They're also available to critical incidents. So if anything were to happen on site that would affect a large number of employees or even a small group, we can have on-site counseling provided to debrief this critical incident. Okay. We also have training available. On-site training is one of our services that we can provide. There's a huge menu of different options that you can choose from. Fantastic trainers that are really specialized in the area that they're talking about. We would love to discuss that with you if you'd be interested in that. All right, the next slide is going to dive in on 238. It's going to dive into more about those peer support groups. This is going to include some of the information that we can provide on a flyer that you can provide to your employees, so they have more information about getting enrolled. Okay. All right, so on page 239, we're going to discuss the AI chatbot that we have that's called TESS. This is going to be in effect on July 1st, 2021. And this chatbot is an emotional support and wellness chatbot. So she'll do check-ins to boost wellness with employees. So there'll be an assessment that employees will quickly answer, and that'll help her get to know them so she can kind of do a better job of checking in and reinforcing some skills, and then referring to the EAP also. This is kind of a 24/7 availability chatbot. Any questions so far?
Any questions? I have a quick question. I don't know if you're going through more and saving questions to the end, but so according to the utilization report, it was for a short period of time, last quarter of 2020. We only had 19 people. I understand it's a new program. But by your history, what do you think we should expect to make it worth our while to continue?
So our standard employee assistance program utilization is between 3 and 5%, or 3 and 7%. It just depends on the demographics of the client. Every client's different. I would say to shoot for 5%. I think that's kind of a medium engagement effort, and we definitely want to make sure that we are staying engaged with materials, newsletters that come out monthly, and those webinars that are available monthly. That really helps boost engagement, and they're free for you to share with them.
Okay, thank you.
Absolutely. That was a great question. If you have any more, feel free to stop me, and I'm going to go ahead and move on to the renewal on page 240. So that rate for the renewal for the 6 visits is it has been $2.15 per employee per month. We are going to not increase that rate at all, and further, we are going to give you a 3-year rate guarantee. So that will be the 2nd year, 3rd year, and 4th year that you'll see there will remain at $2.15. And then I am happy to go in more detail of the utilization report. If you want to start on page 244, we can kind of get into some of the demographics.
Hey, Keely, this is Aaron. Keely, this is Aaron. You don't have to go into the detail because we know it was only basically 2.5 months of activity, so I think we're okay with what's been done so
Does
far.
anybody have any questions? Questions? Susie?
No question for now. Thank you.
Okay. Well, thank you.
Okay.
Thank you. You have Vernell has.
Just a quick question. What closes a file out? Is that after 6 visits, or what makes a file close?
So once they've been authorized is when that will close the file out. The providers will typically come back with us with any outcomes that they have to provide to us. But we close it out as far as our system once those have been authorized to the provider.
Does that answer your question? Very much. Okay. Anything else, guys? All right, nothing. Thank you, Haley.
Yes, you're welcome. My pleasure.
Okay, and I guess we are right on time. And we move on now to basic life, AD&D, voluntary term life and short-term disability review, identity theft benefit option review.
Madam Chair, this is Aaron. If I could interject, Amanda's texting Bill to make sure, because we're just a tiny bit ahead of schedule.
Oh, yeah.
But to tee this up a bit, what we've done, we had a kind of a late request for the identity theft items to be in there. And so Bill Oakes is going to just do a real quick recap because it's a multi-year rate guarantee. It locked in a bunch of savings, and I wanted to give him that opportunity. But then what he's going to really do is turn it back over and then to go through those 3 identity theft options. Because it came in kind of at the end, what we did is we had them priced with and without some form of county subsidy. We didn't know which way the county was going to go. We did not prepare any numbers, but frankly, they're pretty easy. So we thought walk through, give Bill his chance to talk about the life and ST short-term disability, then have the 3 identity theft proposals, and then when we get to the costing of budget options, we can go into detail on how you want to approach those subsidies, if at all. Okay? So, Bill, are you on the line?
Yes, I am. Can you hear me?
Okay, make sure you speak up, and I'm going to drop off.
Okay. Okay, everybody can hear me okay? Good.
Can everyone hear,
Hi.
Mr. Oakes?
Yes.
Yeah.
Everybody good?
Yes,
Okay,
you're
good.
fine.
Well, thank you, board members, for having me here today. My name is Bill Oakes, and I'm here to talk about the life and disability, and it does start on page 258 of your packet. But like Aaron said, I'm not going to go through that deck too much because of the ID theft protection. I'm going to defer most of my time to my guest speaker, Jenin Cruz, who's also on the line with me. But I do want to give you a real quick recap on the life. So here goes, or the life and disability. Here goes. So the life insurance is through Securian, and we were fortunate enough to win your business last year. And on the employer-paid life, we offered a 54% reduction on rates. And on the short-term disability through Madison National, we offered a 21% reduction on rates. So those two combined provided $140,000 savings per year to the county. On the life insurance, we gave a 5-year rate guarantee, so those rates are good until the year 6/30/2025. And on the short-term disability, it's a 3-year rate guarantee, so they're good until 6/30/2023. So I do want to save most of my time for the ID theft protection. I'm going to pass it to Jenin, but is there any quick question on life or disability? Otherwise, I'll pass it over to Jenin.
Any?
No? Jen? Okay. Jenin,
can everybody hear me as well?
Can you repeat that, please?
Sorry, I was just confirming that everyone can hear me as well.
Yes, I can hear you now.
Great. My name is Jenin Caruth, and I've partnered with Bill and Aaron to present a couple identity theft solution options for the county. Thank you guys for taking time today. Just in general, identity theft solutions are intended to help your employees monitor high-risk areas of their personal lives, receive notifications of any unusual activity that's occurring with their ID. In general, ID theft products monitor common information such as social security numbers, email addresses, credit cards, bank accounts, credit scores, even things like lost wallet protection and surveillance. So the way I wanted to kind of break this down today was first and foremost to start with pricing. And that is going to be on the bottom of page 284 in your packets. So I'll just give a little bit of time for everyone to get turn to that page.
I think it's 283. Is that correct? 283?
Yeah, it starts on 283, but then the actual prices are on 284.
Oh, got it. Okay, thanks.
Yep, you got it. So down in the bottom section, the header states features and services. You'll see voluntary monthly cost and employer paid monthly cost. What you'll notice that jumps out right away is that the product from ID Shield on the far right is by far the most expensive product offering, and that's regardless if it's paid for by employees or by the employer. So because of that, what I'd like to do is really spend the majority of the time comparing and contrasting the Cyber Scout program with the LifeLock program. Again, you'll see in pricing that the two programs are very similarly priced. And these are both what I'd call the Platinum or Cadillac programs. In the formal proposals that are included in your packet, they do offer more basic versions of each program. But based on my conversations with Aaron and what you were all dealing with, we wanted to present kind of that Cadillac solution. So again, you'll see with Cyber Scout, the voluntary monthly cost is $9.50 for individual, $17.50 for family. LifeLock, $9.99 per individual, $18.98 per family. If you, as the county, chose to sponsor a portion of the premiums, that's where the employer-paid cost would come into play right below, $5.75 for individual on Cyber Scout, $11.25 for family, with LifeLock, $5.49 for individual, $10.98 for family. Any general questions just on pricing at this point? Okay.
I don't think so. I'm sure you're going to tell us the
Okay.
difference between the two.
Yes, that's exactly right. So there's a lot of information in these side-by-side comparisons. So what I've done is pulled out strengths and weaknesses between each company, and ultimately our job is to present this in a way where you guys can all draw your own conclusions on which product is going to make sense, most sense for the county. So starting with LifeLock, the strengths of LifeLock are really in the brand name. It's a recognized solution for your employees. So if you're recommending and offering this solution, you're going to have that level of comfort with your employee population. In addition, Norton Antivirus is now a part of LifeLock, and what that means is individual software protection can be included in the package for your employees. So they can download Norton Antivirus software onto their personal computers to help provide some extra layers of virus protection with their devices. The other strength with LifeLock, being that it's a brand name, it's a large corporation, it's very intuitive as far as the user interface, how employees register, and how they utilize the system on an ongoing basis. So that's just kind of general strengths of LifeLock. The weaknesses to point out with LifeLock, and one that I frankly kind of find somewhat ironic, LifeLock itself as an organization has been hacked on multiple events to the point where there have been multiple lawsuits filed against LifeLock as an organization. They've addressed those and fixed many of those areas, but it is something that I typically draw attention to when we're talking about the company. One thing LifeLock also is somewhat limited around is their social media protection. This is becoming a more and more common area, and it doesn't matter if you're 20 years old or 70 years old. People have Facebook accounts, Twitter accounts, Instagram accounts, and these are common areas that are now being hacked. LifeLock today does not have comprehensive social media protection. Another area where that's a weakness, LifeLock covers your immediate family and children up to age 26. Trying to extend that above and beyond that, kind of that immediate family is not included with LifeLock. So just shifting gears, the strengths of CyberScout, unknown commodity outside of the ID theft space, but very strong reputation within that ID theft space. They do provide that social media account monitoring. They also allow you, and this is really unique, they allow you to cover not only family members, immediate family members, children over age 26, but they allow you to extend the coverage to parents, grandparents, parents-in-law, and grandparents-in-law. So me as a 41-year-old, I can extend this to my 70-year-old in-laws who are at higher risk of having their identity stolen, and they can utilize this service through my account on that family pricing. CyberScout also has higher indemnification amounts. So if my identity is stolen, they will cover up to $2 million, whereas most other companies cover up to $1 million. The weaknesses of CyberScout are going to be, frankly, in the unknown brand. Your employees are going to say, who is this company? How do they work? Compared to LifeLock, they do have somewhat limited reporting capabilities. And reporting meaning like quarterly reports on the status of your identity. And then they're also unable to provide that extra layer of software protection in the form of a Norton antivirus that LifeLock can provide. Any questions really just kind of between the two, LifeLock and CyberScout?
Any questions? Can I ask, what does two-factor authentication mean?
Yes. Yeah, so if you've ever logged into a website where it asks for your user ID and password, and then it will follow up to say, I'm going to send you a code to your cell phone or your email address. Please enter that 6-digit code to get into the site. So what it does, it's that extra layer of protection. If someone steals your email address and your password, they're not going to be able to access that information without that 6-digit code that is sent to your phone.
Okay, we do that all the time now, right? With PayPal, all of
Yeah,
that.
exactly.
I just want to real quick tell the trust here, the trustees, that there's a reason for us wanting to do this. The chairman of the board asked for it to be done as well. We've had issues. We have had issues with the trust itself, having some issues, and then we've had problems with identity theft for unemployment benefits and things like this. So we've been asked, we were going to do it anyway, but we were asked by the chairman of the board to also look into this. Right? Anything else I need to add?
No, madam.
Okay. Susie, did you want to say anything?
None at this time. Thank you.
Okay, we can continue.
Great. So just some final kind of bullet points, and really in general, in relation to the scenario you're dealing with the county, with individuals having their identity stolen. One of the biggest things that really stood out to me with both of these services is that pre-existing conditions are covered. And what that means is any employees who are currently experiencing identity theft occurrences can start working immediately with a case manager. Now, what it would not include is any indemnification for any financial loss. So if my identity was stolen and it resulted in a $10,000 loss that occurred in 2020, the case manager or the company would not be able to reimburse me for that, but they can help and provide assistance from essentially unraveling this scenario that I'm dealing with. So again, both organizations, immediately when this goes into effect, those employees who have had their identities stolen can start working with the case manager to make sure that they're on the correct path forward. And I think that's a really big deal because if you've got a handful of employees who are experiencing it today, they should be able to get some immediate relief and assistance right off the bat.
Madam Chairman,
a couple other.
Yes.
Go ahead.
Oh, I do have a question. Norton sometimes offer this for security for the computer. If employees have it already in their personal computers, would they be would this package that you are presenting under LifeLock be similar to what they have gotten in their security software in their own personal computers? So which means it's not necessary for them to have this with Mojave County.
Just the Norton component specifically, you're correct. There's some redundancy there. If I have Norton downloaded on my computer currently, this would be redundant in that situation. But what Norton doesn't cover is the credit monitoring, bank account monitoring, Social Security numbers. It's purely software antivirus.
But they also have a
software.
component of if you want to buy the LifeLock with them.
Yeah, so if an employee has already purchased that on their own, LifeLock has a retail benefit that you can go online and purchase. I can tell you that the cost of that retail price is going to be more expensive if I buy it on my own than if I get it through my employer. So there would be a benefit to that employee with some cost savings.
Okay, thank you.
And I can say that for myself, I have it too, and it is much more expensive. So I think it would be something that the employees would like if it's something that the board wants to do.
Okay.
Okay. Anything else?
Yeah, just two more real quick points, and I'll wrap it up with my last statement. But one other component, these plans are portable. And what that means is if an employee leaves employment within the county, they can continue this coverage. With CyberScout, they can continue at the same rates that are shown. With LifeLock, it would just transition to that retail pricing. And then just in general, if we provide and assist with education in how to utilize these services to the fullest extent. You know, really, this is going to provide a significant peace of mind to your employees and give them that instant access if something does occur in the future.
Now, I do have a question on that point. You're saying that if an employee leaves Mojave County, they could portable. This program is portable. Would Mojave continue paying for that benefit for this employee that left?
No, they would just work out a direct billing arrangement with the vendor that you choose.
Okay.
It would kind of be like Cobra, right? You would just pay for it direct. But you would still get the reduced rate? Would you still get the county rate?
With Cyber Scout, you get the reduced rate. With LifeLock, you would go to the retail rate that's reflected, on their website if you were just to buy it on your own.
Great. Great question, Susie. Okay. Are you through with your presentation for the security?
I am finished, and I know we're on a strict timeline, so I wanted to make sure we adhere to that.
Thank you so much. And now?
Yeah, Madam Chair, so where we're going to go at this point is we're going to go into the actuarial and the budget building. My suggestion, if I may, Madam Chair, is we're actually doing great on time. We might want to take a 10-minute break, give people a rest, and then come back in, and we'll hit the actuarial report, and then we'll do the budget building.
Okay, does anybody need a break? Yeah, you do? Okay, let's take a 10-minute break.
Hello?
Hi, this is Chris from Buck. I think we're on a break.
I think so.
Yeah, I've been on for the last 10 minutes or so, and they just took a break, so
Okay, all right.
they should be back any minute.
Okay.
Three minutes? 2 minutes? Not going back to the voluntary term life and short-term disability review. Not. Okay. Okay, great. Okay, waiting for Roger.
Yes.
Okay, I'm going to call this meeting back to order, and now we are going on to the review of actuarial renewal report and benefit change up.
Okay, so Madam Chair, I'll tee this up a little bit if I could. Chris Marshall is on the phone. He's the actuary that we've used for the trust for many, many years, Buck Consultants. And I always joke that this is one of those rare actuaries who speaks human. He actually speaks other than in statistics and in jargon. But just to tee this up a little bit, so this is the part of the meeting every year. What we just did is what I call the look under the hood. How's it performing? Medical, dental, vision, script, how's it all looking? You kind of got that look. And I know that people's eyeballs roll around in their head. But the trustees need to have that basic information come into this conversation. So, and every year we do the same thing. The actuary does a presentation, he discusses the rates, and we walk into the benefit design. As in past years, the trust comes into this conversation in very solid financial position. And I emphasize that not to minimize what you're about to do, but the trust was started about 20 years ago on a very weak footing. It took us about maybe 5 or 6 years to get it financially stable, and then to build to the point where we had our IBNR covered, and then later we created a surplus reserve. We are, in fact, in the middle of the storm that the trust was built to withstand. And if you look around, Roger and I accepted nobody's running around with their hair on fire, okay? Because we've got money in the bank, okay? That's not a reason to be complacent. It is a complex conversation. Healthcare is inflating, ballpark about 7% in a good year. This year, there's a lot of oddities because we know, for example, that we took the hit of about $1 million in COVID claims in the trust. We absorbed that body blow, okay? We also know that hanging out there is deferred and delayed care. So the delayed care is if you need a hip replacement and you couldn't get in, that hip's still going to have to be replaced. That's going to come through at some point in the future. And we know that deferred care is things like mammograms that people delayed where they may have cancer that's going to get caught at a lower place. That's not Chicken Little. That's just recognizing the complexity of the world we're drawing breath in today. So as you come into the conversation, what we did with Chris for talking about basic rate setting for next year is we asked him to essentially run 2 sets of numbers. What would the rate increase be if COVID hadn't existed? So if the world was just stable, where would you have come in? And then recognizing that COVID's a reality and we do have things like deferred and delayed care, if you were going to look at COVID and actually considered your numbers, what would you do? So we asked him to do both of those. And I wanted to walk you through that because you are legal fiduciary. You're going to make the decision on the rate, but I want you to understand, have Chris explain to you how that whole thing works so you make an informed decision. That's really, at the end of the day, what your duty is as trustees, is to make an informed decision, okay? So we'll go through that. His base number basically assumes you make no changes other than those that might be imposed by law or regulations, like the zero option, no changes, right? And then we'll go through and we will do, when we get into the budget, we've had some requests for some different benefit changes, and we'll go through and price those, and you'll ultimately make the call, okay? You're not going to do that until the afternoon. So I know you've been through a lot this morning. I know there's a lot of eye rolling because it's a lot. But I would ask you to listen, to engage with Chris, to challenge, to understand his numbers so when we get into the dialogue on the rates, then we can go back and forth also with staff, with Coral, with Sam, with Ken, all those with your staff, and kind of flesh it out to how all of that really comes down to where the rubber hits the road for the county. Frankly, this is the most engaging part, and I hope you will take the time. Just dig into a challenge, ask questions, throw bricks, whatever it takes to make sure you understand how the numbers were arrived. Okay? So, Chris, with that, you're teed up.
Okay. Thank you, Aaron, and thank you, everybody at the Trust and Madam Chair. So I was going to start us off on...
Chris, can you speak up, please?
Sure. I was going to start us off on page 316. So as Aaron talked about, he got into a little bit of the development methodology. So I'll go into that in a little bit more depth. So for our projections, we assumed a trend rate of 7% for medical and prescription drugs and 4.2% for dental. Those are annual rates. Those are based on national averages of what we're expecting to see in the next calendar year. As usual, we did a separate analysis on medical and dental, and then as Aaron talked about, we did make adjustments for COVID-19. So those are mainly in 3 categories. There's the costs that are associated with testing and care, so the actual disease itself. Then there's going to be expected future costs coming because of care and going on with the virus. And then finally, the impact of the lockdown and what Aaron talked about is deferred care. So there were tests and procedures and things that weren't done during the lockdown, and then that continued where people were not maybe quite as anxious to go see the doctor about something that wasn't life-threatening if they could avoid it. There's also going to be some costs for people that, because they didn't get routine tests done, perhaps they would have, if they would have, they would have caught something and found out they had stage 1 cancer. But if they waited and then went in later, then they found out it was stage 4, and then the costs for that could be a lot higher. So there's going to be that loaded in as well. As you'll see, we use 24 months of experience. So we have 12 months ending calendar year 19 and also 12 months ending calendar year 20. So moving on to the next page on 317, we're going to show you the numbers coming up on the next 2 slides, but for just to sum up where we're at, we are projecting an 8.1% increase for medical, and this includes COVID adjustments. As Aaron mentioned, we did calculate it in a world without COVID, and then we added in the expected COVID cost, and we did a range. So you could go anywhere if you wanted to be aggressive or conservative or pass the exposure on to the fund that you have built up. That's what we're going to talk about today, but we had a range of 4.2% to 12.2%, with the recommended being 8.1. For dental, as has been the case for the last several years, we're recommending a rate path. The experience continues to be to run very favorably, and as of now, there's no need for an increase.
Chris, can I ask you a
Moving
question,
on.
please?
Sure, go ahead.
Okay, just back to the development methodology, and I keep hearing this, the costs associated with testing, I think it's testing, just testing. I thought that the federal government was paying for all testing. So are the insurance companies being reimbursed for those costs? Because I know that Access is. So is it just one of those things that they just expected the insurance companies to pick up? Because all we kept hearing about was free testing.
Yeah, the testing is picked up by the insurance company, and it's supposed to be free to the employees, so there's no charge. But if there's insurance, that test is getting paid for by the insurance company.
And the insurance companies are not being reimbursed by the federal government?
Not that I have seen, no. Now, that's the case for the vaccine. The government's definitely paying for that. But there's still, there's costs coming in for all my clients where the tests are, they're being paid for by the insurance company, and those are getting charged against the experience.
I'd like to know what the costs are. I'd like to know the cost of those tests because, people are getting them all the time whenever they have a hangnail or something. They just want it because I think they think it's free. I do. I think they think it's free. So if it's not, I'd like to know what the cost is so we can pass that on. Okay, thanks.
Yeah, we do have a report that shows what all the COVID costs are since the pandemic started. I don't know that it would take me a little bit to get it broken out between the testing and then the care and things like that. But yeah, we do have that information. So.
Okay, thank you.
Yep.
Madam Chair, may I?
Sure.
Really quick, in answer to Supervisor Angus, you indicated that the cost for testing is in the packet. Can you answer the question without going to the packet and looking through it to confirm what she just said of her understanding? The testing is free to the individual, employee or otherwise. If you have insurance, they're billing your insurance. I guess her question is, and mine too, is the insurance obligated to pay for it and absorb the cost, or is the insurance turning around and invoicing the federal government? That's I think the point of question here. Thank you.
Yeah, Madam Chair and Sam, the puzzlement, we all looked at each other because we know that, for exactly what Chris said, we know that the cost to the employee has to be essentially nothing, right? So the plan has to absorb it. This is not an insurance company, it's a plan, but we both looked at each other going, did something change since January, for example? Because none of us is aware of anything where an insurance company can bill back the federal government for recovering those expenses. I guarantee you there's a note that says, did we miss something? Okay.
Okay, so then the next question would be, because, usually you just can't keep going, getting the same medical test over and over again, except this. So is there, since we're now paying for it, I thought it was free, all right? And so now that we know that we basically are paying for it, the insurance is paying for it, it is still a line item. Is there a limit of how many you can get, or some kind of criteria, or is it really just up to that person how many times they want to get tested?
That's exactly right. So when the federal government came out with the CARES Act, there was nothing in the language. Our compliance team looked at it, and it was just no cost to the members. They wanted to make sure that the general public didn't, try to put things off. They wanted to make sure that they went and took care of themselves if they were showing symptoms. But the burdens of the cost was on the employers or their insurance companies to cover those costs. Yes, so your average cost was $76, was your average cost per shot for COVID, or not shot, sorry, for the testing for COVID-19. Then you also had testing for antibodies, which was also covered at no cost for the members, which was $42 average.
The antibody test is covered. So if you go, because you have to go to a testing lab like LabCorp or Sonora, and they charge you. So you're saying I could give them my insurance card and it would be free?
It would be free to the member, yes.
Okay, I didn't know that, and I don't know if everybody else in this county knew that, because people have asked me, and I didn't give them that information. So thank you.
You're welcome.
Madam Chair, can I point out for the record that on 3 separate occasions in the last 3 minutes, I heard the chair say free without the qualifier to the member? You have been corrupted, Madam Chair.
Well, when I say free, I really I thought that everybody was being reimbursed by, they're going to print some money up there and send it over here.
That would be nice, yes.
That's what I thought was going to happen. Silly me. Okay.
But the clarification also, just so as we're on the topic, the vaccines, though, the actual drug itself is covered by the government. But to administer it, those costs are still charged to the insurance company or the employer. So if the drug costs, it's $0, but if it costs them $18 to do the shot, then that's going to be applied.
Just out of curiosity, is that a set fee, or can each provider make their own fee?
It ranges between, we've seen it range between $15 to $22.
Okay.
Mm-hmm. Madam Chairman, this is...
Yes,
hello?
Go ahead, Susie.
Yeah, I go back to the statement of Sam, because, what about those people who are getting tested, who are not employed, and who don't have any insurances, but they're still being tested? Who pays for those? The reason I'm raising this is I go back to the statement of Sam that says maybe there's a provision wherein these insurance companies have to bill the federal government for the expenses they've incurred, or the provider of service, the one who did the testing, can bill somehow the federal government other than the insurance or the employer if they're not employed or they don't have any insurance. Maybe there's a missing link there of billing the federal government for these services, by the insurance or by the providers when they provide the services to people that don't have insurance, are not employed. I mean, somebody has to cover the cost.
Well, I think with that here in Arizona, it would be access because they sign you up for access before you do anything. But again, I was under the impression that the federal government was going to reimburse the state. But anyway, this is kind of off topic. It's just an interesting. So maybe when you get a chance, you can find out and stuff. Okay. Anything else, Susie?
That's all for now.
Okay, continue, Chris.
Okay. I'm on page 318. So the medical and prescription drug rates are the development of summarized here. Now, this is for the scenario where we pretend that COVID did not exist. So on the first box of numbers is the calendar year 2019. Second box of numbers is calendar year 2020. Of course, there's no adjustments for COVID in 2019, but in 2020 there are. And what we did was, you'll see the first line there is enrollment. The second line is the actual paid claims. Then we back out claims that are directly associated with COVID-19. So that's the testing and any inpatient charges for hospitalization and so on, and the care of COVID-19. So that's all backed out. We then have added in an estimate for services that were not provided due to the lockdown or just people staying away from the doctor for, quote, non-elective procedures. That adds a little bit back in. We then calculate the incurred per employee per month. That's the $753 and the $760, so for each of the two time periods. There's been some plan changes, so we adjust for those. We then add trend, so that's the annual increase that we're expecting, so that's added in at in the next group of numbers. Then we have the plan enrollment shift. This is a measure that captures your movement between the two plans as well as between the tiers. So if a lot of people suddenly started to drop their dependents and only had single coverage, claims would go down because we wouldn't have as many people being covered per employee. So that's what this is measuring. The movement is usually pretty light, as you see here. It's not even 0.2% 1 year, and then it's almost 0.5% in 2020. We get incurred claims per employee per month of $895 and change, and $849 and change. We blend those 50-50, so equal weight, take the average, and we get 872. And then that is compared against your current funding rate times all the enrollment, which is 869. So you're almost exactly right on budget. It's not even a 0.5% increase. So it's 0.4. So that's in a world without COVID. On the next slide is 319, and of course we do have COVID, so we're going to look and build on that $872. And we've got the factors listed here for what we would anticipate to happen in the 7/1/21 to 6/30/22 time frame. So we have the testing, which we do not expect to be as significant at that time, but there will be a little bit. We talked about the administrative fees for the vaccine, so those are loaded in there. And we have the three different columns, I should have said before I started. So we have the recommended, and then we have that bracketed on either side by an aggressive and a conservative assumption. That there's other issues that are going on. There's the direct hospitalization for COVID, long-term medical issues. We're seeing people that had COVID and maybe they weren't hospitalized, but they're having long-term issues, primarily respiratory. At least at this time, that's what we're finding. So there's going to be a small increase for that. Hospitals are increasing their unit costs throughout all this. It's a little bit of additional trend that we're seeing, so we're adding that in here. Behavioral health is is getting a lot of headlines lately, especially among children. The lockdown and being isolated away from schools, that caused a lot of issues. So there's going to be some behavioral health claim increases. And then additional high-cost claimants. So these are the situations where I mentioned before, where somebody didn't get that test, that preventative test, or skipped their physical last year, and then they find out this year that they've got something and it's progressed, it's very far along, and it's now going to be a much more complicated road to recovery, and that would mean higher claims. And then there's going to be some completion of deferred care, but not very much. But we do anticipate some there. So once those are all taken into account, you can see the numbers at the bottom of the page. It's a 4.2% increase minimum. Recommended is 8.1, and then on the high end we have 12.2. I know I went over a lot there, and there's a lot of numbers. Does anybody have any questions on the development with COVID or on the rates in general?
Any questions? No questions.
Okay. The next slide is 320, and that's the dental rate. So it's the procedure here for the development is exactly the same as it was for the medical, except that we don't have COVID really to worry about as far as adjusting for future. But we did make an adjustment in 2020. You'll see that there. It's the third line, and over on the right, it's the 78,268. So that's actually during the lockdown. What claims were not happening because the doctor's offices were all closed. And when they reopened, some people came back and got care, but many did not, or they just skipped that 6-month cleaning. So it caused a decrease in claims that we're not going to anticipate seeing in the future. So we need to put that back in there to project out going forward. But once we get done with the projection there towards the bottom, you can see the weighted projected incurred claims is $54.81. The number below that is the current composite premium rate. So that's your current funding rate times enrollment. That's $58. So you're still projected to come in under your current premium rate by 8%. So we recommend keeping your dental rates flat. And then on page 321 is just a summary of your current funding rates, and then the minimum, recommended, and maximum rates that you would have under the scenarios that we presented above. So I didn't know if you had any questions or wanted to talk about what, because in the world without COVID, you would have a 0.4% increase, but because we're expecting costs, we're recommending 8.1. I didn't know if you wanted to talk about where you wanted to end up or have any questions around that.
Okay, any questions? Yeah. Okay, we're good.
Okay.
Okay, so Madam Chair, if I may, then at this point, what we can actually do, I think, is we can let Chris drop off for the time being. And then, Chris, are you still on the phone, Chris?
Yes.
All right, so I think what we can do, we can let you drop off just out of respect for your time. We have your text, so we'll text you if we need to and check your availability as we go into kind of the budget building discussion. If they have any back, if that works for you, then we'll just do that, Chris.
Okay, yeah, that's fine.
Thank you very much. Thanks for your presentation today.
Thank you.
Okay, yep. Thanks, everyone. Bye-bye.
So, Madam Chair, just as background, so again, I think I'm being a little bit presumptuous here, so feel free to call me out on it. But I think the conversation is really going to wind up being about what level of funding do we do versus massive changes to the plan, because the baseline numbers are fairly decent. There are, however, some changes that have been requested that I want to call out to the trustees, because Amanda has, you'll remember, this is our mystical, magical budget and rate building program where we do it in real time. But I want to throw them out and then discuss with the trustees which you want to consider. And Ken can feel free to jump in here. There are essentially three, two of which have direct rate consequences. One is to reintroduce hearing aid benefits. I'll come back to that. The second is how we treat essentially surprise medical bills, where somebody goes into a hospital, does the pre-cert, does all the hoopla, but then the hospital assigns an out-of-network provider. We'll talk about that one. And then the third is what's called dual spouse coverage. And this one does not impact the budget per se, how we treat things. So on the hearing aids, the background on this is that we used to have a $1,000 benefit. Years ago, we had a $1,000 benefit for hearing aids, just a dollar amount. This is an only in-network plan. People could go in-network. The most the plan would pay was 50%, $1,000, and there was a time clock on it. We ended that benefit, I believe, 2 years ago, not due to any utilization issues, but what was happening is that there was a particular dominant vendor in the market that was contracted with Blue Cross, and part of that contract is that for whatever the device is, this is the amount you get reimbursed. And the $1,000 budget paid for about half of it, right? But the vendor was then ignoring essentially the Blue Cross contract, billing whatever number they decided they want to bill, and we were getting a series of appeals. So we literally just yanked the benefit. And the rationale, quite frankly, was in trying to do a good thing to offer this benefit, the trust was being projected by that particular vendor as doing a bad thing. They had to keep denying these appeals. The issue, frankly, in play there was the reimbursement rate between the vendor and Blue Cross. The vendor wasn't happy. Okay. So having said all that, we did price three options. We had a request from somebody who utilizes hearing aids, came through HR, and we had a request to price three levels or some benefits. So what we did is we priced $1,000, $1,250, and $1,500. If you want to look at that, we can put those in. And that number, whatever that number winds up to be, goes in addition to whatever level of funding you have, you choose. So if you said we want to look at the 4%, we'll click the 4%. It'll show you what the rates do, and then we would add the hearing aid benefit or not. It's kind of FYI. The second one is somebody goes into the hospital. So they go in a normal delivery of planned C-section, anything you want. Pick the procedure, but they go in, they call American Health Group, they go to an in-network facility, they pre-certify, all of that is done, and then unbeknownst to them, that's the important part of this, they did nothing wrong, the hospital switches in a provider that is not contracted with Blue Cross. Okay, so the member has jumped through all the hoops. This is not uncommon, particularly with things like anesthesia, orthopedic surgery, neurosurgery. There's specific areas that the vendors are limited enough that they choose not to contract. Okay, so what happens on the plan is the plan then pays that provider based on the usual, customary, and reasonable for that charge. And Rick or Marina can jump in on this, but we use what's the 80th percentile, right? So they have to be that charge has to be within an average of what 80% of those people in that billing zip code would charge or in that area would charge. And that's what the plan pays. Any excess of that gets paid back by the member because that's not a contracted provider. They can bill whatever they want. Okay. So this plan is doing 80% UCR based on 80%. And we had an instance this year where a member got caught in that. I believe it was with an anesthesiologist, and the anesthesiologist said, pay it all. Was that you? Okay. So we had that priced out to just say, okay, we'll pay what's billed. Okay? And basically, at that point, you say to the plan, all right, the member did everything they did. We don't want them getting caught. We'll just pay what's billed. We'll attempt to negotiate it, but we're going to pay whatever. Okay? Those are the only two that have rate consequences. So, I mean, I don't know how you want to do it, Madam Chair. If you want to talk about the baseline rate and then look at those increases, I think that might be a better way to go on it. Amanda's passing me a note. Did I miss something? Oh, and then also, I'm sorry. And then when we get into the third one is that whole Livongo Omada expansion. That is one of them.
Okay, with the hearing aid, is this something that a lot of people are asking for? I mean, it's not a common. I mean, we paid like $6,000 for my husband's hearing aid 5 years ago.
We have a very small group of individuals that use it. We've been asked, I think, like 3 or 4 times throughout the year if we had hearing aid. And then we've had one that was been very vocal, so that's why we asked to price it. But I would say we have less than 20 employees that have even come and talked to us about it, or I should say 20 members. 20 employees, but 20 members. But since we've stopped providing it, because we've had 3 or 4 vocal people, and that's about it.
And if I could, Madam Chair, just think about it, because I'm the one who just added the confusing element. Let me try to get rid of the confusing element. I think a better way to approach this would be to have the discussion about, you've heard Chris's commentary on how we treat COVID, right? And then do you go, where do you wind up? So I think if you want to have that conversation, how do you want to treat COVID based on the report? That'll get us back to which box we check for the baseline increase. Is it 4? Is it 8? Is it 12? Is it 0.4? What is it? And then you'll have a real world. We can click the boxes on Livongo, on the hearing aid, on the out-of-network charging, and you'll come to a final number. I think you'll do it quicker that way. Okay? You want to lead the conversation, Madam Chair? Do you want me to kick in? How would you like to do it? Okay, all right. So here in the bigger picture, here's how the funding for the trust works. We really have 2 sets of rates in effect. We have an adopted set of rates that is the legal set of rates, if you will, and where that becomes significant is COBRA. Okay? So when somebody leaves the trust, the county employment, and they're paying for benefits, they pay 102% of that rate for the first 18 months, and then if they are qualified for extended COBRA, which takes them out an additional 11 months, to pay 150% of that rate. So that rate is the actuary's full, it's the fully developed rate, it's the free one. There's a lower rate on a practical level that's in effect for the county, and that's the funded rate. And the reason we have that rate set in lower is that the trust financial position is so far beyond its targeted position that rather than continue to build money in the trust that could be used for public services, the county has made the informed decision over the years to fund less than the actuaries recommended to try to find equilibrium so we're not constantly banking money, right, while preserving the surplus, the IBNR and the surplus. So basically, instead of trying to throw a football through an open garage door, what the trust has been doing in cooperation with staff is try to throw that football through a mail slot. So how do we just keep it level, and how do we break even because we're where we need to be? So when you adopt a rate, we're going to adopt a rate that is based on Chris's number. It's going to be 0.4% to the funding factor. It's going to be 4%, 8%, or 12% funding factor. Then on top of that, that's the pure claims. Those dollars are just the claims, the money that pays claims. We'll add the administrative component, and that's the complete rate. Okay? So my question to you, you've heard Chris, And what Chris basically said is, if COVID was not here, the trust has run well enough that he would only increase the medical rate funding by 0.4%. Okay? If you build in to the reality that COVID has been there, his minimum would be to increase it by 4.2%, I believe it is. Recommended is 8%, and then the maximum is 12%. Okay? So in terms of the funding, the real question is, how do you feel about that? How would you want to, as fiduciaries, treat COVID? For the record, we're about, Coral can help me out on this, but I believe we're somewhere north of $1.5 million in excess of our surplus reserve target. Okay? That is not me encouraging you to short fund. That's me giving you the information you need to make a decision. Okay. Long story short, and I had this conversation with various people in the trust, the chair, the county manager, Coral. We're in a very good position. Okay. What that surplus reserve gives us the ability to do is do exactly what we did this year. We absorbed the body blow of COVID costs for testing, for treatment, $1 million. We're still sitting $1.5 million or something to the good. Okay. What you should be aware of, though, is that we've got two things in operating. We've got an adopted rate and we've got a lower actual funding rate, which is working well. Okay. The vulnerability is how wide that delta between the adopted rate and the actual rate grows, because if things do change structurally, then what happens is you have to make up not just the short funding, but you have to make up that incremental cost for the structural change. And I know that sounds theoretical, so let me give that delta the real thing that I think about when I think about Mojave County's trust. Historically speaking, and Rick and I were looking at some of these numbers, I'll drill this one in later on after the meeting. Historically speaking, about 70% of hospital-based health care that this trust pays for goes through Kingman Regional Medical Center. Okay? On any day, Kingman Regional Medical Center, KRMC, is an expensive hospital. Ballpark is about 30% higher, all things being equal, okay? About 30% higher than the care delivered in Phoenix or in Tucson, okay? So if they renegotiate their contract with Blue Cross, and that 70% of hospital-based healthcare goes up materially, that's a structural change in your cost. That one doesn't go away. COVID is going to go away. I'll say that boldly. It's going to go away. But a change to a hospital that represents 70% of your costs, that's not going to go away. Okay, so you got national healthcare, national inflation about 7%. You got a bunch of our costs are going to a single facility. I tell you that because that's the vulnerability. That's the chink in the armor. Okay? So when you're looking at that delta, when you're looking at your funding, when you're making that decision, know that you come into the conversation in a very strong place. But in terms of how many legs are on your table, we've taken one of them out because we're funding lower, still successfully, but we're funding lower. And the real wild card is what happens with the rate charge at Kingman, right? If they do a 10 or 8 or 12% increase and it hits the codes that are most common with you, then what will happen is we'll have about 2 years, in my estimation, based on today, we would have about 2 years to correct our funding, to adjust for that, and the only thing we'll do, minimize the disruption county budget doing. Does that all make sense? That's in my weird consulting brain when I look at Mojave County. Those are the different pieces that kind of move around. If I may, Madam Chair, or Rick, do you have anything you want to add to that? So I'm brilliant. Anyway, all clowning around aside. I know that's a lot, but that's really what I think about in there. So I would just say, just don't get too comfortable with that delta, because if it does, and it does happen, this is not theoretical. The reality is those combinations of things happen. What would do it? A combination of something bigger than COVID. And in Mojave County, we've seen bigger than COVID. We've seen large cases go up by a multiple of 2.5 in a year, combined with a significant increase in Kingman Regional's charge, right? That would be a structural change. That would hit. We would be putting a 2-year plan together at that point to minimize disruption.
Erin, when do you expect the Kingman to be renegotiating their prices?
They can do it anytime. Their contract with Blue Cross and with these carriers are evergreen, so it's really whenever they decide they want to do it. It's just it's an ongoing fact of life. A good question. The question is there a notice or you find out? What typically happens, the real world, what typically happens is the negotiations are going on and we don't know because they don't tell the Blue Cross doesn't tell its purchasers, hey, it's going on. What happens is the contract negotiation hits an impasse, and then to ratchet up the pressure, the hospital typically, whatever hospital happens to be, will put the word out in the community. We're canceling our Blue Cross contract on this day. So it's a little bit of pistols pointing, if you will, and then that's when everybody starts getting involved, kind of running around. And frankly, what typically happens is that gets the hospital an extra point or two on the negotiations, and then the contract.
Question. Just out of curiosity, has there been any discussions on what could happen with Biden Care as we go into this next year, and how does that play into any of this stuff we're talking about?
Excellent question, Madam Chair, Roger. Frankly, our assumptions, and we actually went out to dinner last night, Rick, Marina, Amanda, and I went out to dinner last night, and that was about a third of our conversation, is that what we believe is coming down the line, I think what everybody believes is coming down the line, is going to be added cost plans and employer. So we know, for example, one that we've been monitoring for a couple of years, and regardless of politics, because frankly, this is not, at the end of the day, no one cares what your politics are. It's about what it's going to cost me. Yeah, but for example, with the Supreme Court ruling under the last administration that discrimination against transgendered individuals is prohibited under Title VII of the 1964 Civil Rights Act. Okay, so you can't discriminate against a transgender individual in the terms and conditions of employment, because doing so is ultimately a discrimination based on their gender, right? Because that was couched as terms and conditions of employment, benefit is perceived as terms and conditions of employment. Okay, so we are prepared in the background with roughly drafted out language to add transgender surgical benefits, pharmaceutical benefits, psychological benefits to all of our plans under the assumption that a court ruling is waiting or an administrative guidance from the current administration that says you have to add those benefits. Okay, so I picked that one. I'm cautious in picking that one because I realize that one can be a political lightning rod, but we expect that level of expansion over the course of this administration, not just legislatively, but administratively. So we are aware, or we are expecting a broadening of benefits cost to employer.
Anything else?
Another question was just because you've been the go-to person, the advisor for this program for a number of years, still are, but in a different, somewhat of a little bit different capacity. So where do you fall on recommendations percent-wise?
Madam Chair and trustees, if I had my drug, okay, what I would tell you is that it's always better to put a couple of points in a year. Do 2 points, do 3 points, just to kind of stay ahead of the curve. I recognize in the case of Mojave County, I am going to make a recommendation, or tell you what I would do. I recognize in Mojave County, this thing has performed so well, so consistently for about the last 5 years that any recommendation beyond the minimum is going to be challenged. If it were me, I would hit that rate by 4. I would do the minimum. I would not do the 0.4, I would do the 4. And that would keep me sleeping better. I would put into that where I think the biggest change happened. It happened about 5 years ago or so when we changed what we did for the Nevada area specifically. What we did is we contracted with Aetna for their POS2 network because we were getting killed on emergency evacuations to Las Vegas. and the network structure we had just didn't work. It hadn't kept up. We put theirs in night and day. I mean, just claims dropped. That leads me to one last point. You're sitting here in this position, all of us, including myself and my team, and we're sitting here in this position because for the last 20 years, the people who sat in those chairs and the staff chairs made hard decisions, right? We are all getting the benefit of that collective number of wise decisions. And frankly, all of us will pass from the scene too, one way or another. So as you're doing that, and you guys have always done this trust has always truthfully have done a great job of recognizing that the financial solvency of the trust has to outlive anyone. So well done. Good luck. I would do 4%. I don't know if that's going to happen. I would do 4 and call it good.
One of the things we discussed at our pre-meeting, and so much of this has to do with COVID and either real COVID numbers or, future COVID, maybe not. The CARES money was put in place to offset those kinds of expenses for all county services. That's what they said, although it's kind of now vague. You can use it for anything. So what I asked is that if it should hit, like if we didn't do anything, any raises, and it hit us, because you yourself said that it's going to go away. It's going to go. So it's not an ongoing thing for, decades to come. We'll have other things for sure. If we had a sudden, problem with, numbers, could we use CARES money to just supplant, put it in to make up for those costs? And, FYI, we're going to be getting another boatload of CARES money, it appears, out of this COVID relief, that $1.9 trillion. Hard to even figure around how much. So that is something, too, I think that the trustees need to keep in mind, too, that there's that option instead of, us funding it or putting it on the employees. That we have this third option that we may not have, we've never had. Does that make sense? Do you want to add anything, Sam?
No, perfect. Madam Chair, you're absolutely right. You're on the mark. The third stimulus funding will likely come with some guidance. We don't quite know a lot about it yet, but it's likely to have some flexibility, and the board will have discretion. So thank you for mentioning that, reminding everybody of it.
It's a good problem to have. I don't know in the whole scheme of things if it's good, but for our purpose, it's a good.
Hey, Madam Chair, I would just
Madam Chairman. Oh.
Yes, Susie.
Yeah, regarding your statement, are you recommending or are you saying that we shouldn't have any increase at this time because we're expecting the CARES money or the CARES program to take care of those increases related to COVID?
Well, again, I want to see the numbers when we do it in your magic sheet here, but I just want the trustees keep in the back of their minds that that is an option too.
Okay.
When we look at all the numbers.
True. All right. Thank you.
Yeah, Madam Chair, I was smiling a little bit when that question was asked. I just want to point out too that as the consultant of the trust, Roger, one of the balancing act for us is we're going to be conservative, right? But I do have to temper that with the knowledge that the thing is running so well. So I'm trying to, what I'm very deliberate is never to be Chicken Little, because I think when you're Chicken Little, you lose your credibility, right? So I'm always going to be conservative and say, given the uncertainties, like you're talking about the administration, what's coming next, blah, blah, and that's really where the 4% comes. I sleep better at night knowing there's extra money in the bank. I'm also very cognizant of the fact we're that far above our targets, and the county has vital services to provide to citizens. So that's why it's not a hard and fast recommendation. That is my comfort level.
Right. And one more thing, if there should be some catastrophic or we are, a bomb dropped and we have this, negative, we can come together in an emergency meeting and do something about it. It's not like, well, we're set for the year. We can never go back and change it. We can always go in and fool with it.
And Madam Chairman, just to follow up on my response to Chairman Angus, I was mainly explaining what I know about the third stimulus package. I by no means and I am implying or suggesting that we don't do anything. I think there is a lot of wisdom and merit in your suggestion that we consider something less than the recommended. Let me put it that way. And that is up for the rest board members to contemplate and vote on, and be happy to offer some suggestions when we get to that.
Hello?
Wait, Susie, did you want to say something?
Yes. No, I think people are not speaking to the mic, so we can't hear what, I didn't hear what Aaron was saying. I didn't hear what you were saying the last time.
Oh, okay. I'm sorry
No, but
about
that's
that.
okay.
We keep
That's okay.
forgetting.
Touche. I apologize, Susie, I had my microphone off. So I was just saying, I think if we could, what I just did is Amanda's up on the board. Susie, I don't know if you're able to log in and take a look at that. But
Yeah,
what we can do
I
is
am.
check, okay, good. We can check the box, pick a number, we can check the box, the 4 tenths, the 4, the 8, the 12, and then tell you what our recommendations are on the fund, on the benefit changes. Click those, you see where you wind up, and then we can go from there.
Okay.
Madam Chair, what is your preference on the funding level?
I don't
4
know.
tenths, 4, 8, 12?
Oh, well, mine is going to be as low as possible, obviously.
Okay, 4 tenths?
Yeah.
We'll start
try
there.
the
You can
fourth.
check, we
What
can
do you-
check the
what
box
do you
anytime,
think?
uncheck.
Well, it should be the whole board should, you know.
Madam Chair, understanding that the 4% point four or 0.4% was for assuming no COVID.
Correct.
There is COVID, unfortunately, and we need to be realistic about it. My suggestion to answer your question, Madam Chair, would be we start with 4%.
Is that okay with the trustees? We'll start at 4. And then 0.4, yeah, 4 as opposed to 0. Just start. We're just looking at the numbers now. Okay. Okay?
And then so, yeah, so then, you know, let's look at what the 4 looks like. Can you make that bigger? If you're looking at on the screen.
Now, what page are we in now, Aaron?
We have on the screen, Susie, I'm trying to get it to bigger so you can just see. I want to show them what the dollar changes are.
Susie, this is a spreadsheet where the numbers change when they put in different numbers.
Okay.
Are you online? Can you see it?
Well, I can only see what was uploaded online, but I couldn't see what you're doing right now. That's okay.
Right. You can see it online, right? You can see the screen with the numbers, the spreadsheet?
No, I couldn't.
Are you on YouTube?
No.
Oh,
That's okay. I'll go into YouTube. I was just looking
Yeah.
at what has been downloaded.
Yeah, up until
Okay.
now, you didn't
Go
really
ahead.
have to because we had it in front of us, but this is something different.
Yeah, go ahead.
All right, so if you look, if we were, and again, we're in discussion purposes, this is just a matter of checking box, okay? So if we checked and did 4% increase on the funding, well, actuary's minimum, it actually translates to about a 5.2 to 5.5% increase on each of the tiers. The reason for that is we have to load the admin changes on there. and oh, he's going to click it twice. Okay, so it gets a little bit above 4. The reason for that is we have to load the admin changes, and we have built in the largest increase we've built in for stop loss. We had to do 30% this year because of the known large cases and what we know is going. Okay, so with that combination, it gets you up to somewhere in the 4% range. Scroll down. Yeah. Right here. Okay, so, and then it gives you here on lines 39 and 41, it gives you what the dollar change is by tier. Okay, so that's what actually the dollars that would actually go for people that were in the employee only, employee spouse, employee child, employee family tiers, whether they're on the EPO or the high deductible health plan. For the record, just to make this easy, the dental rates don't change. His assumption is 0, so there's no change in the dental. Okay, and then if you scroll down to the bottom of the budget, all right, so that would represent about a $707,000 change in the budget to do those two things.
Sorry, I'm kind of lost here.
What part, Madam Chair? Where do you want me to go? All right, let's just stop. Let's get away from the computer for a second. So there's essentially two components to the budget. The claims fund, which is literally just that, what we pay claims. And that's what the actuary gives us rates on. And that's about 85% of the budget. So it's actually about 78% of the cost is just claims, and then the rest is overhead.
Okay, so that 11 million, that number, what is the?
Pure claims, pure medical and dental claims. Okay, and then all those other line items below it are the overhead, the reinsurance, the Meritain's fees, our fees, all of that. Okay, so Chris's number, the actuary's number, only impacts the claims component. Okay, so we take that, and then if you see these lines that are in there by color, what they are, it's a visual for us that we know that yellow is anything that's going to hit medical, blue is going to hit dental, and it's so then when we build the rates, we add all those components together to come to what looks like an insurance premium. Okay, so in this case, just using this figure, the 4%. So what we did is we just said, okay, if you make no other changes to the plan, we up the funding by 4 point whatever it is for Chris's minimum, and then add the fixed cost assumptions on the top, the 30% to the reinsurance, we juggle everything around, then you wind up at these rates that Amanda's got on the screen.
Madam Chair. Madam Chair, may I?
Yes.
So, Aaron, to your point, we suggested a 4% increase based on the understanding that COVID is here, COVID is real, and it has some impact. And you just said that is somewhere around 78% of the total dollar amount, mainly claim.
All that's
the rest of it is overhead and admin.
Correct.
Do we have reason to believe that overhead and admin is going to be increased by that percentage or similar percentage? What's the industry expectations are for the admin aspect of it? Because why would we want to use one number for both when it may not be for?
Good question, Madam Chair, Sam. Because each of the admin components moves individually. So the real driver on the change this year is that we know what the large cases are that are hitting the reinsurance already, and we see the ones that are coming. So we're making an estimate this year that the reinsurance premiums, that protects the claim from getting, essentially the trust from getting bankrupted by large cases. We're projecting a 30% increase. Normally we project 15 to 20. That's just a big impact. So it's a guess. We won't really know what that number shakes out to until May or June. So we budget based on what we really think. It's not even a worst case scenario, Sam. what we really think, okay, that's reasonable, that's possible, it could happen. Last year, we missed it. Okay, we were high last year. And so what happens then is we have essentially a contingency line item, our general admin line item. So when we miss it, we shift everything down to general admin. So this one results after we took all that back out. So we used the miss from last year to offset the change for this year, but we still wound up where we wound up, 4 point something. Amanda's got something she's going to walk through with you.
I just wanted, is this on? So I just wanted to explain a little bit just to make sure, too, that maybe Aaron wasn't misunderstanding or I'm not misunderstanding. But here, if you see the 4%, when we do that increase, that's when we're marking the box for the 4%, which is affecting the claims funding factor only. But when we go down to the bottom of the budget here, you're seeing this 3.76. That's including the increase to the funding factor, but that's also including the changes we've made to the admin. So that's all inclusive. Okay. And the reason that it's less from the 4% to the, and it goes down to 3.76 is because when we moved those dollars last year, because the reinsurance came in less, that was a $250,000 savings to the county. And so that impacts this budget when we decrease it for this year to show that savings happened. Did I explain it correctly?
So we've essentially washed the excess admin out of it this year to offset some portions of the increase is really what's happening. Same thing you do with your county budget. If you miss it on a year, they're all estimate. If you miss a line item on a particular year, you adjust them on the way through when you get to the new budget. I see confusion, and I apologize for that. So where are you guys at?
How about anyone have questions or anything, Susie?
No, I don't have any question right now.
My only question is to confirm that that is only based on the 4% increase, and we have not added any additional services. This does not include the hearing aid or anything else, correct?
That's correct.
Okay. Thank you, Madam.
And Madam Chair, maybe it would help, again, I know it's a lot, maybe it would help to check the 0.4, okay? And you can see how the number shakes through in between, because like Sam said, you might pick a number in between and say, hey, get this thing to 2%, let's call it good. Right? You could do something like that, and we'll work with staff to do it. So in this particular case, so Amanda's checked the 0.4 of a box, 0.4% to the funding factors for medical and dental. You wind up, roughly 1 point something to 2 point something % by the time you factor in the fixed cost changes. So one way or another, if you did this on the adopted rates, not the funded rates by the county, but on the adopted rates, you're going to wind up, I think, somewhere between, just for argument's sake, 1.7 and 2.4% on the overall rate in here. And on the high end, 1.7 and 4.5%. For the record, every one of those is a legitimate choice. They're all good. Just how lucky do you feel in terms of going forward? Madam Chair, go. I'm sorry. Okay, so I was just going to say, why don't we take a look individually at the Livongo expansion, at the hearing aids, we'll just click those boxes on and off so you see what the numbers look like, and the out-of-network pricing. And then maybe take a break for lunch. You guys can digest, and we'll come back when no one's sugar crashing on top of everything. So, Amanda, why don't you start with the hearing aid on that $1,000 benefit? So the hearing aid, adding the hearing aid in adds, tenths of a percentage point, adding that back in. So now for using that 0.4 increase to the funding factors, we're looking at a range of a 1.7 to a 2.4% increase on the different tiers. Pretty small. Uncheck that one and do the Livongo expansion. So this one's a bit more, it takes the bottom end on this one goes from, instead of 1.7, it goes to about 2.2, and the high end goes to about 2.9%. And then the last one is the end of the in-network. And again, we're gonna be in that range. So we're back here. This one really has a fairly small increase. The bottom is again 1.5 to 2.2. So I think the real conversation here, Madam Chair, if I could, is probably going to be, look, on their merits, you really want to do any one or combination of those on their merits. And then we come back from lunch, check the boxes, look at the final number, and I think my guess is you'll be able to direct staff and us to just say, get us in this range, and then come back with the final number, and we're good.
All right. Is everyone okay with that?
Okay.
Let's do
I would
it.
say grab lunch, man.
So we're done. We're going to adjourn for lunch?
I would say adjourn for lunch.
All right, let's do it.
What time are we going to be back, Aaron?
Same room as rec.
Aaron, what time will we be back for lunch?
We're scheduled for 1. What time do you want to come back, Madam Chair? What? 1:30?
1:30, is that okay?
Yes. Okay. I'll log in at 1:30.
Okay,
great. Okay.
Thanks, Susie.
See you guys. Bye. we going to be back, Aaron? Aaron, when will we be back? Okay. Yeah. Okay. I'll log in at 1:30. Okay. See you guys. Bye. Bottom of the page, 4.2% increase minimum, recommend 8.1, and on the bottom, that's 10. So there's, I went over a lot there, there's a lot of numbers, but that's questions on the development of it, or on the rate in general. Any questions?
phone? Hello? Can we tell if she's on? Oh, okay.
I'm here.
Oh, okay, great. Good. Okay. Let's go where we left off. Okay, I'm going to call this portion of our trust meeting to order. Again? Oh, where's this one? Oh, great. Okay, here, let me. Okay. This is the annual trust meeting, the actual meeting of the Mojave County Employee Benefit Trust Fund Board of Trustees. We have a quorum. And first official business come before this board is a call to public. Anyone with any burning desire in the public? Okay. Next, discussion, consideration, and possible action regarding approval of the minutes of the EBT board meetings from March 27th, 2020, April 9th, 2020, August 26th, 2020, September 24th, 2020, and October 15th, 2020.
I'll make a motion to approve.
Second.
Second. Aye.
Opposed? Motion carries. Number 3, discussion and possible, discussion, consideration, and possible action regarding trust financial reports and audit. Before we keep going, so did we finish what we were doing before, or will it be put in somewhere in this agenda?
It's going to, Madam Chair, it's going to be on item 9.
Okay, great. So, Mr. Collins?
No, I believe this is oral.
Okay.
Ooh, okay, let's make sure this is on. It looks like it. All right. It is. Can you hear me okay? All right. Inside of your packet, I believe it's number 20. Is that the tab? You know?
Not sure on the tab.
20? Okay. Under tab 20. And mine is labeled page number 20. Page number 20 includes like a summary of the budget document, so to speak, a summary of the EBT budget document. We've got a column for the 2019 fiscal year actual expenditures, a column for the 2020 actual expenditures and the actual charges for services, the current year, fiscal year 21 budget, and then the current year, fiscal 21 projected column. So for last fiscal year ending, that for that column, that middle column titled 2020 actual, we collected $13.3 million in charges, which is basically the charges to the various departments at the county. It's the collections from each of the employees, and then it also includes reimbursements that were returned back from the RX and various items like that where the county is reimbursed. The expenditures, we have basically 4 primary categories: personnel services that are charged to the EBT. Supplies and services are quite minimal. The charges for the services, those are where the claims are reported along with the contract portions related to EBT. And then the internal services are essentially the IT charges, if you will, and a few little minor others like copy machine, portion of a copy expense. But those really summarize how the monies are spent through this fund. So for last fiscal year, that total was $12.4 million. We had some transfers back out of there to basically the fund that supports business services for occupational health issues. And then other issues are really just an accounting for, this is really kind of crazy, but pension expenses or the net changes in pension expenses, so to speak. So the beginning fund balance was 9.2. We ended June 30 positively with an $813,000 gain in that fund, and ending fund balance was $10,065,262. Our ending cash was $11.6 million. So clearly the difference between the cash and the fund balance is that the liabilities exceed the assets, and the liability is essentially the IBNR, the incurred but not reported calculation that the actuarial goes through. So our current budget, it is what it is. We've been generally quite similar to prior years. The column for the projected, I guess, is probably of interest then, that we're projecting a slight increase in operating revenues from 13.3 to almost 13.5 million. But the expenses, as have been discussed quite a bit today, are going to be, we're estimating that those are going to be up quite a bit, up to 14.8 million. And so our net revenue would result in a loss of about 1.3, 1.4 million is what we're projecting. And most of that, again, as you've heard, is related to COVID. That being the case, we would end this fiscal year, if this rolls out somewhat where we're projecting, that we would have a decline in our fund balance of the same amount, essentially, and go down to about $8.7 million. And our ending cash would decline down to about $10.3 million. So while that is not good news to experience that kind of loss, clearly what is good news is the financial position that we're sitting in, that we can do this for a few years without really having to react in a large adjustment to both the county or the employees. The next page then, on page 21 and page 22, are the more detailed accounting for those exact numbers. So if you'd like to go over any of that, we certainly can, but it breaks out each of those cost items, and it breaks out the revenue contributions as well. So if there's no questions on any of the line items themselves, on page 23, we have just some images of the cash flow over the last 5 years and how that goes, up and down, kind of like an erratic heartbeat over the period of months, but has continued to be on a positive trajectory since about 2016. And then the bottom image is the fund balance, and the fund balance in each of the years has continued to be above the minimum recommended reserve since at least of 2014. Page 24, I won't go over a lot, but it's just another way of analyzing the claims history over a period of time and how they are different between July through December for each of the past 3 years, and then claims history January through June for each of the past 3 years. And in 2018 and 2019, there's a section that is just to the right of the graph, the chart that's on there, and it's in really small letters. But in each of the prior years, the first half of the calendar year is where the bulk of the claims have been. So all of the claims that occur, let's say in the fall of each year, our year for expenses is actually on a calendar year for the EBT fund, but we are on a fiscal year as the county. So I'm assume, based upon prior history, that employees, especially if they were on the EPO and had an FSA, would want to get all of their activities that they had related to occur before December 31st. And therefore, claims occur at a higher range in January, February, and March when those bills start coming in. But this past calendar year, things were different, where COVID was occurring earlier on. I mean, obviously it went the whole year, but there was a halt to elective procedures, and then the claims that were received in July through December were significantly larger than the prior 2 years, clearly based on invoices that were coming in, as well as elective surgeries and elective treatments had begun to open up. So then that is it really from the perspective of just the county records themselves of what we process internally, how we put those through our accounting system. The next section, pages 25 through 52, are a draft of the financial statements for both the self-insurance retention pool and the employee benefits trust funds. I would say that the important components of the financial statements themselves, again, show up on page 30. And on page 30, you've got 2 columns. This is the balance sheet with the self-insurance pool showing that they had cash equivalents of $1.4 million. And the EBT had the cash equivalents of $11.8 million. And again, the fund balance for the EBT of the $10 million at the end of that. The following page is what I'm going to call the income statement, as just a layman's term. And again, for the EBT, which is audited, the $13 million in the operating revenue, $12.4 million on operating expenses. Then we've got interest income and expense, and transfers in and out. Again, a net increase in position of $813,000 for fiscal year 20, increasing the final year in net position again to that $10 million. It was an audit without any objective opinions. It was a good audit. Again, so I don't have any other really pertinent data to call out in the statements themselves, unless you have any questions, or if you have any, an opportunity to look at it later and have a question, feel free to contact our department and we'll certainly look into it. And as far as I know as well, we are not expecting any adjustments from between the draft and the final issuance.
Okay. Any questions? Sam?
Thank you, Madam Chair. Coral, on page 20, under operating expenditures, the first line that says personal services.
Huh?
It just caught my eye. It's a smaller percentage when you compare it to the overall dollar amount. It's under 3% versus the 20% that Aaron mentioned earlier when you compare claims and administrative services. So what is in the personnel services? Is it just the employees that handle and manage these
Yes.
activities and
So
services?
the personnel is strictly county employees. So in HR, a certain portion of the employees are charged out, and they're split between the HR department in the general fund and the EBT in this fund. The administrative charges, excuse me, include the contract with the ECA, Gallagher, excuse me. So there are clearly these administrative fees are included, as well as some of the overhead related to the contract.
Thank you, Madam.
Okay. Anything else? Okay. Thank you.
Thank you.
Motion? You have a question? Motion? Oh, we need a motion?
I think we do.
Make a motion to accept the Employee Benefits Trust financial reports.
I'll second that.
Second. Oh.
All in favor?
Aye.
Aye.
Opposed? Carried. Number 4, discussion, consideration of, and possible action regarding continued contract with EAP.
So, Madam Chair, this is the basically the renewal of that. Just the real quick background, we did let go the former vendor, Holman Group, last year. We did add, I think at Berlin's request, if I remember, we added the psychiatrist benefit, I believe, with Teladoc as kind of a stopgap measure. But then as we got into the COVID issue, I know HR got some requests for specifically, I believe, from the health department, but basically saying, hey, can we get something other than that? So what we did is we joint purchased very quickly. We took from the NAEBT, they had just done a request for proposals for EAP services. They agreed to honor the rate. So we put them in, and there was a request at the end, in that conversation to say, well, let's do it for the current year and then decide if we want to continue. So basically that's what this is. So what we did is approach them and said, well, you gave NAEBT a 5-year rate guarantee. If they renew you, will you honor that rate? So if you elect to move forward and honor this, it's what it really is their 1-year contract. So you would renew it from now till next June, and then and the same with all the other vendors, you have the option to renew. From my perspective, we talked with Ken's staff. There are no complaints. People are utilizing it. We have 2.5 months here. It's always a lagging indicator. I would tell you, I think it's worth to renew, continue with the 6 benefit, renew for the current year, and that'll give us a solid year of utilization and customer service issues.
Should we have some kind of internal benchmark as to what would make sense?
As to what? I'm sorry, Madam Chair?
What would make sense? I mean, how many people utilizing this benefit to make it worthwhile?
I do not have an internal one that we use, but I could look. I could ask with Gallagher if they do. Our experience generally is if you get anywhere from 3 to 8% utilization on it of your population, that's pretty normal. Because it's not like medical where you go every so often. It just doesn't have that heavy of a utilization. But I can look. There may be an industry standard that I'm not aware of.
Any questions on that? You need
There's a motion on that too, I think.
Yeah.
Make a motion to approve the contract with EAP Preferred for EAP services for the 3-year period through June 30th, 2024 at the $2.15 PM rate.
Second. I second.
I thought it was only for a year.
It is 1 year. What you're renewing it for the current year. What those other years do is put a cap for you. So you're going to renew it for the current year at that rate.
But we have to renew it every year.
Correct. You still have the option. Yep.
Do we have a motion and a second?
I need to finish the motion. Continuing on a cooperative purchase basis with NAEBT, also authorized ECA Gallagher to work with Ken Cunningham, Human Resources Director, to review the contract and to sign the approved contract effective July 1st, 2021.
Okay. Now, can I have a second? Okay, we have a motion and a second. All in favor?
Aye.
Aye.
Opposed? Carried. Number 5, discussion, consideration of, and possible action regarding identity theft.
So, Madam Chair, I have to start this one with a disclaimer that this is not in our area of expertise. That's why I went back to Bill. They had it. We asked for I had not heard of the cyber, the first one. We had heard of the other 2 and asked, hey, can you get us 3 quotes? And then Bill had a connection with this person. So he went through the presentation this morning. Frankly, I'm not in a position to offer a recommendation one way or the other between the 3. It seemed what I walked away from it with was, everybody knows LifeLock. I personally have LifeLock. He was offering one that he thought was a better option. And then comes the conversation of whether or not the county wants to subsidize any portion of it. Now, we did not crunch a number ahead of time because we didn't know which way you were going to go. But I did confirm that in the event you were to subsidize any portion of the employee rate, that the lower rates would apply across the tier. So if you decide to move forward with this and give us a number of how much you wish to pay, then we will add that into the budget conversation when we get to that. Make sense?
Okay. The pleasure of the board. Now, again, it was asked for the board, and I would like to bring it in front of the board, just because it was asked, and we mentioned we were going to talk about it today. So do we vote, hold off and vote after the board talks about it, or do we vote and then retroactively go back and have the board have it say?
Madam Chair, if I may offer a recommendation, which would be for the EBT Trust Board to vote in the affirmative, but not pick a certain option. Give us staff an opportunity to go through the three options, study them, come back to you, and share those with you, and then we can go to the board with an agenda item and share that with the board. And then at that point, make a recommendation to the board, and if the board as a whole goes along, then we've covered it here. It's a
The
done
motion,
deal.
we can make a motion saying that we approve adding this benefit dependent on the board of supervisors and staff recommendation. Does that sound like a good?
That would be my recommendation,
Okay.
Madam Chair.
Works for us.
Okay, so I, just if you want to say, so, is that okay? Do you want to talk about it? You want to talk about it?
Well, I've got a question. I'm just curious, is this a trend in organizations to help with theft, identity theft? I've always seen it as kind of a personal responsibility. It kind of surprises me. That's all.
I'm not seeing it. We're not seeing a trend overall, Roger. What we're seeing is that the expansion of optional benefits is a trend, and identity theft is in there with things like pet protection, pet insurance. So we are seeing an expansion of that type of benefit overall, and that's actually being recorded in our benefits media because as a result of COVID, yada yada yada. So long story short, that would not be out of line.
I think that one of the reasons that we keep hearing about this is because we've had some issues at the county and that have affected people. And then one of our providers had it, made a couple of supervisors pretty annoyed at it. And I think we did something short term, and then, so we're not saying who's going to pay for it yet. That will be discussed at the board level, that kind of thing. So I think that just saying that we tentatively approve it based on the recommendations coming in from the Board of Supervisors and administrators. Yes.
And Madam Chair, just to add to that, Roger, we have seen a spike in the number of unemployment claims against county employees. We are unsure of the source of the breach. We do not think it's within the county or the county system, but the board was informed of the number of claims, and the dollar amount is fairly substantial. So the board felt the need, as Chairman Angus has alluded to earlier in this meeting, to address that concern and to have us inquire about the availability and the cost.
Okay. So somebody wants to say so moved.
So moved.
And
Second.
And a second. Okay, we got a motion and a second. All in favor?
Aye.
Aye.
Opposed? Motion carried. Number 6, discussion, consideration of, and possible action regarding reinsurance renewal process.
Madam Chair, I'm looking for my memo. Okay, so this is a repetitive item every year, Madam Chair and trustees. As mentioned before, we've got 30% built into the budget for the stop loss renewal. What typically happens is we go out, we shop it, and then there's a process of giving them updated information. They'll present a number, and then when that number gets to a point where we think it's good, then we'll call Ken, we'll walk through it with him, and bind the coverage. Last year, frankly, was a stellar year. We wound up coming in $250,000 under budget. I don't imagine that's going to happen last year. When we did it last year, we called Ken and we're like, sign this now, get it done, because it was kind of crazy. So again, I want you to know we're not budgeting based on Chicken Little. We're budgeting admittedly it's a crystal ball, but what this would do is follow that standard process, which basically says to ECA Gallagher, go shop it, work with Ken and his staff. If you get a good deal, find it and then bring it back in for your ultimate approval. And I think you know this, but I want to make sure, particularly when you present a 30% budget increase, this is included in our fee. There are no commissions included in here. So we're not lining our own pockets with this 30% projection in here. It's a net through to us. I would recommend that you approve this as you have done in the past.
Questions?
Move to approve ECA Gallagher to work with Ken Cunningham, Human Resources Director, to negotiate and bind the reinsurance renewal effective July 1st, 2021.
Second.
I have a motion and a second. All in favor?
Aye.
Aye.
Aye. Opposed? Motion carried. Set number 7, discussion, consideration of, and possible action regarding dual spouse coverage and premium subsidy.
Okay, Madam Chair, I think I'm going to do this one with Coral, I believe, but I'll just tee this one up, or possibly Ken, or maybe all of us. What this is a pretty common situation where a married couple both work for the same organization, and then there are kids involved, and it gets a little esoteric, but it does have real world implications. So this creating a dual spouse class would allow one of those employees to move and become a dependent on the spouse's plan, and potentially save them money. Now, the reason it doesn't save them money today is it actually makes more sense on the premium side for both to be covered as employees and one to cover on the children. A dual spouse benefit, what it would do is you'd slide one of the employees over as a dependent on the plans, and then typically some portion of the county's contribution to that other employee would follow over, and it would reduce their overall costs. I know that sounds complex, and it kind of is, because there's a bunch of administrative wrinkles that go in on the back. So HR has had a request, I believe, if memory serves me, and Ken can jump in, there are 8 people who are in there, who are in this mode. There were some calculations that were done that would show it's a cost item. In my conversations with HR, we were never able to agree to that number, so I want to let Coral and Ken speak on it from their perspective. I believe this can be accommodated financially in a way that is cost neutral to the county. What I don't know is if administratively it can be done.
Who wants to speak? Coral? Where is Ken? Oh.
In regard to the calculations, Aaron and I had spoken about it earlier as well, but theoretically, it should work whereby the county is paying X dollar for a single coverage and a larger dollar amount for an employee child coverage. And if it was combined under one, it would just be one family coverage. And as long as that total coverage is about the same cost as what we were otherwise paying, then it would be a neutral wash. In Mojave County's case, we have that is somewhat benefit from another agency that had worked where this benefit was available. That Mojave County has a employee-only coverage, and employee child, employee spouse, and employee family. So there's a series of tiered premiums that the county pays, that the employee pays, that at this point, we can't get the numbers right in our calculation. So from my perspective, I would prefer to continue to work on it.
I would table.
We've got, overall, it should, by the theory, it should reduce the county's cost to not have to pay for 2 separate plan. When we add in that the employees, if they're on an EPO, then they are paying out of pocket $3,000, I think it is.
Correct. The MAC
$3,000 for the individual, for the employee only, and then they're paying potentially a deductible of $6,000.
family one aggregate that adds together for the family.
Yeah, so they would, so that under the current methodology, then that's $9,000, so to speak, that the employee would be responsible for, not the county. So we have to kind of keep at it until the numbers work, where we can come up with a premium tier, if you will, that is somewhat equivalent to the total cost of the two plans. But in theory, if that makes sense, it should work.
And I think where we're at, just to kind of, I think we're at, Madam Chair, is this one might be a good one to table for a follow-up meeting. Let us get together, see if we can refine the numbers and check out to make sure we're not missing anything, because there are some complex administrative wrinkles, including payroll system questions. But I think we can do it in a revenue neutral way or an expense neutral way. It's a small group. It's an odd one, but we have done it with other clients and gotten it to work. So it again, not knowing the systems, I think Coral and us, we can collaborate if you want to, if you're comfortable tabling and then coming back, we'd be happy to do that.
Madam Chairman, I have a question.
Hello?
Hello?
Susie?
Yes, I have a question. When we are studying this issue, we want to make sure that we're not shifting the cost to the employee under employee family premium. I understand that we may be saving money on the employer side because you're not going to be subsidizing to employees, but hopefully we're not shifting that cost to the premium of the employee family category.
No,
So
exactly.
I'd like to be able to see that the shift isn't there. We're not just saving for the employer side by not paying the premium for one individual or two individuals, but we're not shifting the premium cost to the employee family category.
Yeah, that's understood, and that's not the point. Yeah,
I
we
think
would
the original
try to avoid
intent
that.
was to help the employee on this, right? When the employees
Mm-hmm.
came to you.
On two levels, on the premium and on the maximum out-of-pocket exposure for the family. It actually helps in
Deductible,
both
okay.
ways if we can figure it out.
And the,
Okay.
I mean, if they're on a high deductible, it's it's a different story. They already have that option. So right now we'll pick one. They would be paying more monthly currently on a high deductible, but your out of pocket, maximum out of pocket is significantly less. Or you can have the EPO, which is a lower monthly rate, but a higher out of pocket. So we're trying to work.
Currently, there's 21 couples or families that we currently know of. Some of them are hard to find because they don't have the same last names. And then 10 of those may be impacted. We have 8 of those that have either employee, or one spouse has employee, the other spouse has employee and child. So, and then we have 2 that are one spouse does employee and family, and the other one doesn't carry coverage. They waive the coverage. And so, like was said, the issue that came up and what was brought to our attention by employees is the out-of-pocket maximum, because with $12,100 for a family on the EPO plan plus the additional $6,000, so you're at $18,000, or $9,000 if you're on the high deductible if you have the employee, the child, and then spouse on the other one. So this was brought up, and we thought we would bring it to the board for consideration on if we go down that path. But we were going to bring it last year, but we couldn't get our numbers together in time, and then the numbers fluctuate between, I think it's in section 24, our numbers to be about, well, our numbers say about $50,000 extra to the trust cost. If we allowed the joint.
Okay. So,
Table.
table it.
Madam Chair, I would suggest table because I think, yeah, again, I think we're all on the same page. We're just trying to untangle the knot a little bit, and I think we can come back with a firm recommendation one way or the other at a follow-up meeting.
I don't need a motion for that, right? Table it.
Well, if you take no action, then you'll just have to remember to bring it next. The alternative is
Or if you need to bring it to us and when you
Well,
get
we'll
the
have to put it
numbers
back.
straight.
So just take no action.
All right, so we'll take no action on number 7. On to number 8, discussion, consideration of, and possible action regarding MCEBT vendor renewals effective
Okay.
July 1st, 2021.
And Madam Chair, this is actually in your packet in the last meeting packet, and I apologize, I failed to go through this, but it's starts on page 338 in the other meeting packet.
What tab?
I don't know about tabs.
$338? $15. Okay.
So where do there? Okay. All right, so if you go in there, Madam Chair, these are all the components. I'll skip the first page because that's the funding factor, but if you look, starting with on what I know is page 339, the very first item, number 1, is specific stop loss. This gives you our fixed cost assumptions. It shows the current premiums versus what we're estimating for the coming year. So that's 30% on the specific, 10% on the aggregate, item 2. Item 3 shows the $2.15 per employee per month for the EAP program. Number 4, group life is staying flat. 5, short-term disability is staying flat. Starting under administration fees, Meritain Health, you can see the increase for the current year. They've basically offered, again, 3 years. We always ask the vendors to give us multi-years because what it really operates to do is put a cap on them. So our assumption for this year is that column, the 21-22 rates. And we always give you the budget impact. American Health Group is a rate pass. Blue Cross is going up $1 PEPM. Moving on into Delta. Dental is basically a rate pass on Delta. Slight change on Navitus. ECA's fee is going up $5,000 from $55,000 to $60,000 annually. The benefit, that's the wellness consultant, right? That's the second year of a 3-year deal. These are actually reversed. These two are reversed. I'm sorry. The 6 and 7 are reversed. The consultant fee is staying flat. The wellness is going up by $5,000. Apologies for that. Case management is just a budget amount, an estimate. We made no change in that. The mental health and substance abuse, we carved that out last year. And then we've got the diabetes program is decreasing. It's in nominals, $242 for the whole year to date. Wellness fees are staying flat. The professional service fee is staying flat at $22,000. Then we've got personnel services. Sorry, go ahead, Ken.
I would just like to say something, if I could, on 13, the personnel services. Just for transparency purposes, we are requesting that the budget pretty much stays the same as last year, but in this year that we have 4 new initiatives in place that we're requesting that come to about $16,000 that we had money from last year because of not using all the funding. But I just want to be transparent that I have a couple raises for a couple of my staff and reclassifications in there. So I just wanted to be upfront that even though it says we're going down by $4,000, that 334 includes a $16,000 increase, and then it'll have to wait for the general fund to be approved to get the other portion. But I just wanted, for transparency purposes, that was in there. So it's we still have the $4,000 less than last year, but there is a little bit more money from last
If
year.
it's approved. Okay.
Thanks, Ken. On the miscellaneous expenses, this is the one, this is basically our contingency account. There's legitimate items in there totaling about $55,000 for the current year for meeting expenses and whatnot. But it's actually decreased by $244 from last year. So what we did is we pulled that money and just redistributed elsewhere in the budget. And if we get in trouble on stop loss, then we'll probably dip into this line item. So we use it as both an operating line item and as a contingency reserve. Vision, to call out, Vision came in after the renewal last year. So what happened, since we had put the word out that, hey, there's not going to be any increases, the Vision did go up, and then they gave it a 5-year rate lock. So the trust absorbed the $7,000 increase. So this year we will, in fact, the plan is to pass that increase to employees with the county having absorbed it last year. So pointing all of this out to you basically is saying, hey, these are the fixed cost change assumptions that we make. And the biggest single change in here is the reinsurance at 30. The rest of them you can see they kind of wash through, particularly with that $250,000 taken off from because of last year's stop loss.
Okay.
Okay, so we just have, Madam Chair, that's an issue of disclosure. Hey, these are what our assumptions are in terms of fixed costs for the year.
Okay, are there any questions? Any questions, Ron? Susie?
No question.
Sam? I have just quick, so number 6 is the Gallagher, formerly ECA Wellness Consultant, and then the wellness program fee. So why is it divided into 2 different line items?
Good question, Madam Chair. One is our fee, and the other one is the cost for on-site fees for vendors. So we bring mammography on, and we have to pay minimum or minimum not met fees, that type of thing. So that goes out to other vendors for actual bringing on site.
Okay, anything else? Then I will need a motion. And it would be everything. No, I'm sorry. Never mind. I take that.
So I think, Madam Chair, if I can help, the motion would be to approve the fixed cost changes as included in the.
Okay. Move to approve the following vendor contract as presented and authorized by ECA Gallagher to work with Ken Cunningham, Human Resources Director, to review contracts and to sign approved contract effective July 1st, 2021.
Second.
Okay, motion second. All in favor?
Aye.
Aye.
Opposed? Motion carries. Number 9, discussion, consideration of, and possible action regarding 2021 to 2022 MCEBT budget, benefit changes, and rates. The big one.
Okay, so Madam Chair, we went through all of that before, and I apologize because I realized I struggled in that presentation. I got everybody's eyes rolling around in their head, so I throw myself before the court with apologies, sincere apologies, even though I'm embarrassed by it. We have another wrinkle though now, because now we've got the issue. We have 2 actually. The issue of the LifeLock, or the whatever category you want to call that. Here's kind of my thought is, what I would like to do is punt on this and suggest that we go back, we work on seeing where the Board of Supervisors wants to go on the LifeLock type product. We can then also work with staff on the dual spouse to see if we can get that crunched, and then get some input from county staff on a budget target. And then come back with more firm recommendations. We have the fixed costs done, but we've got those other ones out there, and I really don't think that we can come to an agreement on a rate today. I don't think we're there.
It's a good idea. And then I'm going to talk about some of these things in my administrative report in our Monday meeting. We can't discuss it because it's not agendized, but I can get some, feedback behind the scenes and see what people are thinking, and I think that's a good idea. What does the rest of the board think? Yeah?
I agree.
Okay, great. So we will continue this as well? Take no action right now? Okay, so we'll take no action. And now number 10, an administrative update.
And Madam Chair, these are non-action items, they're just FYI. So we'll
Yeah.
be working with Ken's staff on getting ready for open enrollment, doing whatever material we need. And then once we get back from that other meeting, we'll do the risk management plan for the year, and we'll be off and running.
Perfect. And 11, request for future action. Anything?
I think we have our marching orders. I think we know
I
what we
think
need.
that's it.
Yeah, I
Well,
think we're
thank
done,
you.
Madam Chair.
In this truncated meeting, there was some good, some bad. Well, we'll
Some
see.
ugly.
See the ugly. But thank you so much, as always, for all your hard work, to all your vendors, your staff. We appreciate it, and our staff too.
Same.
And with
Thank
that,
you.
With that, we're adjourned.
Thank you.